Okay, great. Esteemed colleagues, good morning. I'm pleased to welcome you at yet another webinar of Eurasian Arrhythmology Association. Well, you could basically describe it as an anniversary one. So it's the 10th meeting since we started this series. And today we endeavored to kind of mix up all the previous speeches, all the previous reports. It's like a kind of a potpourri. Dear colleagues, good morning. I see all of you there. So we have colleagues from Ukraine, Belarus, Russia, and we also have a special guest, Professor Luca Santini from Rome. Thank you very much for finding the time. And our interpreter, Yuri, whom we've been cooperating for quite a while now. So, deepest regards to him. Okay, dear colleagues, I'm pleased to welcome you here. Good morning. Unless you object, we will briefly recall the first, second, and so on webinars of EURA. And we will start with the brief highlights of the first webinar. Could you please launch that video? So, I'm launching the first video. That's right. Indeed, this was the first webinar. These are the highlights of the first webinar. As you can remember, it came towards the end of the alleged first wave of the pandemic. So we were full of optimism. We were connecting, quite intense schedule, quite intense agenda. Those of you who find the time and who have the interest, you can click the link below to bring up the recordings of that webinar to refresh the memory. For those of you who have not seen it, well, I encourage you to do it even more so. We're recording it today. So now it is my huge pleasure to invite Yuri Karpenko, head of the Odessa Regional Center of Cardiovascular Surgery, to be my co-host this morning. Yuri, this place is rightfully yours. It's too bad I cannot preside with you together at the same table, but well, if you look up the map, Odessa, just go straight north and we'll find Moscow. So we're kind of opposite. We have the summer weather already in late May. The pandemic is coming to an end. I'm convinced of that. Fewer and fewer patients, the moods are improving. people are coming to Odessa to spend the holidays. I hope that our webinar will contribute to more optimism in treating, managing patients with severe diseases. And once the diseases are over, once the diseases are treated, people will come to Odessa to recreate. Yeah, just a reminder, Yuri Karpenko is the founding father of our Arrhythmology Association. Back in 2013, we decided that it is time to combine the effort. It's time to unite. And you know, the outcomes of this cooperation was formerly this program, the one that you are looking at during our webinars. 1,300 applications of membership, 1,300 members, a congress that we've made. And in September, we're looking forward to the second session, second congress of EURA, with participation from our colleagues from Minsk, Republic Scientific and Practical Center of Cardiology, Professor Mitkovskaya personally. She put a lot of effort to it. We hope that the meeting will take place in mid-September this year in online format. Please let me announce the scientific part of our agenda, and completing the memory of the first webinar, I would like to give the floor to specifically you, Yuri, as a co-host and as a reporter, to deliver your talk about cardioresynchronization therapy, CRT, once the pandemic is hopefully over. Well, sooner or later, it's bound to be over. So the floor is yours, sir. Thank you very much. Just, well, two questions in the same sentence. Well, when the pandemic is going to end? Well, most likely this year, possibly even this summer. CRT, well, I will try to take this question in my presentation. How we do it together, how it might look like tomorrow. Cardiac resynchronization therapy is indeed super idea, like syncing up two ventricles operation. More than 2 decades ago, Kazol did that for the first time, delivered the first results in patients. So there's no question that CRT is a method of treating people with blockade of the left bundle. More than 10,000 people, patients, randomized CTs with significant improvement of life quality. You see the sinal veins. For 25 years, we've been looking for the Holy Grail, and we seem to have found the perfect solution to this problem. However, up to 30% of people do not respond to CRT. So there must be some other philosophy, some other Holy Grail that we must be gunning for. And I believe it has been found. And let me get there in my talk. The classical indications, it's left bundle blockade, broad QRS, ideal sinus rhythm, but there must be some clinical markers, such as specific functional class of heart failure, also some possibly couple months. Unless there are improvements, well, we go for CRT. The broader the QRS, the better indications are, but they're quite high for the moderately expanded QRS complex. You see the grade 1A indication. If there is AV blockade already, there's no other option. CRT, resynchronizing devices, or a conventional pacemaker. For broader indications, you don't have to wait for the left bundle blockade. It could be just broader QRS, right bundle blockade. However, well, the QRS is supposed to be longer than 150 milliseconds. Okay, what about the dogmas that we know about? Traditional stimulation of left ventricle, of right ventricle is bad because it causes asynchrony, and in up to 30% there is a pacemaker-induced cardiomyopathy. However, if patients with moderate HF receive the stimulator, their improvement is also far from perfect. high mortality, high hospitalization, readmission rate for heart failure in case of AV blockade, because it's not perfect. This methodology is not perfect. In the past decades, there's been a serious growth of interest, practical interest to direct stimulation of the His bundle and the left His bundle. So, unlike the three-chamber stimulation, it's more physiological because it is improving. It is synchronizing the left ventricle with the right ventricle. It does it simultaneously. Not too many RCTs in that area. However, there have been a number of individual works, articles, collective articles that have shown the benefits of these direct measures. So the benefit of these direct measures. Patients with issues, with cardiac issues, specific ones. So what is a tri-chamber stimulation? This is the chart. You see the lead stimulating the epicardium of the left ventricle. Well, it takes a long time for the pulse to get through the thickness of the myocardium and the Purkinje fibers system to activate it. We see this path, and no matter how hard we try, the 30 non-responders will be there because, like I said, it's not always physiological, and the pulse is supposed to be reaching from this proximal and distal sections. There could be some asynchrony of the pulse movement in the lateral wall of the left ventricle. These are the classical works that show us the activation of the right ventricle, left ventricle in sinus rhythm, 55 milliseconds for the LV, 60 milliseconds total. Right ventricle, you see the blue, the later zones, lateral wall, and the time for the left ventricle activation changes, it doubles. For the stimulation, the LV is improving, but not that much. Total time is still exceeding 100 milliseconds. So no matter what we say, no matter what we like to say, unfortunately, the classical CRT is not biological, although it does help two-thirds of the patients. So we've been walking this path in the dune, this long road in the dunes with the cardiologists when epicardial stimulation didn't help, or we couldn't do it physically. There could be dislocations, there could be high thresholds in the vein. So together with other scientists, we would do the function of the intraventricular septum, and we would implant this electrode to the basis of the papillar muscle. This is the lateral papillar muscle. It's affixing to these walls, and the participation, well, in 30% of patients, this mitral insufficiency goes away because the pulse reaches the lateral valve and the basis of the papillary muscle instantly, much quicker. So the severe mitral insufficiency it goes away, the patients become hyper-responsive. This is the QRS, only 98 milliseconds. This is a not sophisticated surgery, it's also quite safe. So we have walked that path, like I said. This is the appearance several years on. The patient came to us several months ago, and you see how, you clearly see the 6 years after the implantation, how the fixation to the septum, how it looks like. Functional class is quite good for the patient. We replaced the device in 2020. Well, there will be some payment for the foreign body, anticoagulant therapy, foreign body in the heart. However, patients have atrial fibrillation, anticoagulants are still already indicated just by virtue of that. So no issues there. This is the biventricular stimulation, one of the patients in 5 years. Right ventricle, we upgraded the 227 milliseconds is the pulse width. So we've reduced the QRS complex by 100 milliseconds. So we're paying a lot of attention to this mechanism, asynchrony, because CRT is not electrical therapy, it's mechanical therapy. So what we get is this kind of synchronicity. Before the surgery, we see asynchronicity. Now we see it improving. Different phases in the septum. So the lateral wall, the width could be up to 300 milliseconds. 300 milliseconds is a mechanic systole of the left ventricle. And you see them strictly aligned here, only 19 milliseconds difference. So we've got a very good mechanical resynchronization. You don't even have to look at the patient's EKG because the main mechanism is right there. It's improving the mechanical geometry of the left ventricle contraction. The GLS was 5.6 and it went up by a single percent, by 1%, just several days on. So that's like what, 20% improvement. So that's in a matter of days. Several months on, it will be even better. So these are the apex of the left ventricle. You see how it's implanted. We've done this with the surgeons already. This patient has been compensated for quite a while. Classical cardiomyopathy with left bundle blockade. So quite a decent functional class. This is the kind of path that we've taken. And well, it was quite tough. It was quite dangerous, and we were very happy to learn about safer and more reliable methodologies of electrophysiological system of the heart stimulation. Vijay Raman, it's a great person that brought back this philosophy to life. We see the left cross of the AV bundle stimulation. This is the true physiological stimulation. When we are stimulating the natural conduction system, and we get a very good synchronicity of the LV and RV. These are very fine. This is a very fine, tricky section in the his bundle. Basically, these are muscle fibers which are protected by fibrous tissue, and there is a very thin section. It's very difficult to pinpoint it and to place the leads. There's no muscles in there, so the thresholds for stimulation are too high. You miss the muscle, the sensing will be poor. So it's a very sophisticated piece of work. His bundle, the AV bundle stimulation is reaching only as low as 30%. And that's the gurus of this technology I'm talking about, the best of the best. The Purkinje fibers, well, this is a huge network that we've seen, that we've always known about. Any stimulation in LV with utilization of this conductivity system will be very efficient. How we've done it, we're supposed to focus on these sections of the conductivity system so that the pulse is moving naturally. So these are the basically the sections of the heart conduction system that we believe to be perfect. It's the AV bundle itself, the his bundle itself, and the left cross sterol. Activation of both the septum and this also. You don't have to stimulate the left bundle directly. You have to be close enough with the lead so that the pulse is touching it and kind of pushing the pulse in there. There are visualization, there are imaging technologies that help for every patient, that help determine the anatomy of this heart conduction system. They are showing the perfect sections in the cardiac conduction system where the leads are ideal for placement. So distal stimulation of the left bundle. These are the fibers of the left bundle. Right bundle is in red. It's a very good chart that shows the localization of the cardiac conduction system. This whole thing started several decades ago. Dr. Deshmukh, who treated patients with low ejection fraction, with chronic atrial fibrillation and narrow QRS complex. These were conventional leads. The technical possibility was only in 2/3 of the cases, stimulation of the His bundle. Well, it started 20 years ago. Then they forgot about it for a decade because it was tough. There were no specific tools, particular tools. And once again, I'm bringing you back to the guru of CRT of today, Professor Vijay Raman. Basically, the heart conduction system, well, he's done a lot of work in his center, immense work to spread the word, to disseminate this methodology for the heart conductivity system. So this is clearly the leader in this direction. We've also recalled these small leads, Medtronic leads, very narrow ones for French. No, they were intended for small children. There could have been blockades after open heart surgeries. So these are the special leads that are used. Well, they were originally intended for a different purpose, but they are used to stimulate the His bundle. These are the delivery systems, special delivery systems that are guiding the lead towards the septum and towards where the AV bundle is. So the vendors that come up with this sort of technology, with this sort of medical devices, well, the appearance is pretty much like this. Unfortunately, they're not registered in Russia, but in Ukraine, we've been using these systems, Medtronic systems, for 3 years. We're quite happy. We started using the Biotronic system delivery system because it's more robust per se, and the lead itself, well, it's a conventional 6-French lead. Could have been made by Biotronic, could have been made by Ventricular. So these are some good cases that we've collected by now. Biotronic system gives success pretty much every time. This is how it looks schematically. The implantation into the CCS, cardiac conduction system, the implantation of the His bundle. You see my hand and the piece of that valve, I guess, or part of the septum that is sometimes gets out. So it's a very thin lead. It's very difficult to position it. It's very difficult to screw it in. However, well, you just need to practice. I mean, it takes some practice. First 5-7 cases have been tough. However, it was a downhill climb afterwards. It's a routine methodology ever since. So it takes some trying to get to know it. So His bundle HV interval is 55 milliseconds. If we put in the electrode and stimulate the His bundle, we will get an identical EKG in 12 leads. 55 milliseconds, same time before the onset of the peak. So this is the QRS complex is not changed if it's normal. In left bundle blockade, we can overcome it and get QRS aligned. So what if the His bundle is not particularly accurate? Is it good or bad? How do you distinguish them? So this is a non-selective His bundle stimulation without this interval. And this is the right ventricle stimulation. See how these complexes are different? This is a trial in Poland 2 years back. Very nice patterns here. Very even QRS. And there's a plateau on the right-hand side, the right ventricle. And there are some notches below. So in V2 and V4 leads. This is the pulse. This is the pulse coming from the left ventricle to right ventricle. In this case, right ventricle is stimulated, then the left. So this is bad, this is good. And this was proven in a trial when the endpoints of heart failure and hospitalization, death and heart failure hospitalization, they were not statistically significantly different. So if you have para-His stimulation criteria, if you get there, it is a success for those patients. So we have never known that His bundle stimulation can be used to overcome the blockade. This is the higher current because the amplitude is very low, and it's coming through the blockade of the left of the left cross. So this is the theory of longitudinal dissociation of his bundle. It was proven 100 years ago, Kaufman and Rothenberg, but we didn't give it too much thought. We couldn't clinically use the knowledge that was collected for us 100 years ago. So the higher and higher amplitude current is passing through the left AV bundle blockade. So once again, selective stimulation of his bundle is quite tough, high thresholds, this dislocation. So the scientists have been focusing on stimulating other cardiac conduction system stimulation with smaller defects. And this nice methodology of direct stimulation of the left cross was introduced by the Chinese scientists. It's quite easily done initially. Well, the initial appearance is quite easily done if we control the morphology of this V1 peak. If it's a broader QRS, right ventricle, and then it takes this kind of configuration. RS, and it's becoming quite narrow. The QRS becomes quite narrow. And in some cases, we record the signal, the PV signal. 20 milliseconds, somewhere around that. So this is how it looks. Location-wise, this is his bundle location, 15 millimeters from it, towards the apex is this zone, this area. This is the CT imagery that shows the positioning of the both leads of this electrode. And the LAO X-ray. This is how it looks. This is the positioning. In 2019, this methodology was used for the first time. Left cross of AV bundle stimulation. This is where it is, 178 before the stimulation, and the QRS duration drops down by 50 milliseconds, just like that, by 60 milliseconds. This is how it looks on EKG. This is how it looks on the imagery. This is this is more or less the place where Purkinje fibers are in the left bundle. So this is what it looks like. A right bundle is in blue, the left bundle is in green. His bundle is right there. AV node is in yellow. So rel 15, 30 degrees, it's quite easy to find this. However, you also need to look at the morphology of the QRS complex. We'll get to talk about that a bit later on. So quite significant experience has been generated by some clinics, the Chinese clinics, 632 patients with attempted LBPP. Success rate is nearing 100%. They've been able to penetrate the blockade. Mostly patients with AV blockade and 88 patients with left bundle blockade. So what did it lead us? The stimulation parameters were quite low, I mean, the thresholds were quite high. The stimulation of his bundle, you see the QRS complex is reducing, the blockade is going away, the left bundle is going away. You see the ejection fraction improving. The sinus node is quite strong, it's not getting weaker. Hemodynamic parameters, everything is fine. I mean, it's a good way to electrophysiologically stimulate. Quite a big series of patients have been used to demonstrate it. Just one more example of the kind. Left bundle blockade. So this is RAO, LAO is perpendicular. And this is for the anatomy. This is his bundle and the left bundle lead that goes into the left cross. Okay, so these are the patterns. For those of you who want to look at it, this is prefixation, distended, extended QRS broken up, and then the QR appears, and then ultimately in bipolar pacing we get this kind of QR interval. So this is one of the important criteria. The second criterion is basically the stimulus here, stimulus before the peak of the R. So this activation of the ventricle is supposed to be less than 80 milliseconds. QRS changes in V1 lead, and this is a significant shortening of this interval in V4. We've reached the endocardium of the left ventricle, so this is most likely the perfect place to leave the electrode right there. So these are the criteria that we used. Well, other criteria that are recommended, well, we haven't seen them work according to our experience. Sometimes we even get it wrong. Later on, you program the parameters. In some cases, you need to shorten the latency. In some cases, you need to extend it. So we get the lowest or the narrowest QRS with these settings. So these are the optimal parameters that you need to select by trial and error to get this, to avoid the left AV bundle blockade. So we stimulate the left cross, and we automatically receive the incomplete, sometimes complete blockade of the left cross. This is the EKG that we get as a result. In some cases, an LV lead is supposed to be also added if you're not getting the right QRS. In this case, it will be the left bundle and left ventricle pacemaking. This is a CRT. There is a trial that is combining both technology. So how do we avoid the situation? We stimulate the left ventricle, and it's good. It's going to contract quickly and simultaneously. However, when creating this left bundle blockade, it's not well. It's not cool. We need to correct that. AV delay must be corrected, or bipolar pacing. Monopolar, bipolar improves the QRS just like that. And the more sophisticated technology is an additional lead, an additional electrode. Tri-chamber stimulator is required on the right-hand side. Middle part, just a bipolar pacing is sufficient. So these are the two techniques, quite reliable, quite simple ones. This is how it's supposed to look like, very narrow QRS and lack of right bundle blockade. Okay, let's venture forth into this topic. This is the correction of patients with cardiomyopathy, non-ischemic one, left bundle branch pacing. Success was reached in 97% of the cases, 61 out of 63. And we're getting back to these patterns that we're supposed to be looking at. It's V1 lead and the lessening of this phenomenon to the R peak. It's becoming so much shorter here. And it's better, you don't have to screw the electrode further in, not to perforate the interventricular septum. This is how we started 3 years ago. Of course, we started with the his bundle stimulation. This is the mitral valve. It's a very good biological milestone, very good biological. And we're adding the his bundle blockade as well to make sure that the electrode is easier to get to the implantation site. This is the his stimulation, perihis stimulation is quite good. This wave is okay from the viewpoint of mechanics. Very good mechanics of the contraction of the ventricle. We determine the thresholds. This is follow-up already. QRS is as short as 88 milliseconds if you stimulate the his bundle. And this is the left bundle blockade. It was overcome quite nicely with this technology. This is the second option, the more pragmatic or reliable left bundle branch stimulation. A bird in the tree, a bird in the hands is much better than two in the bush. So basically this mechanic delay is getting reduced. This is how we pass through the septum. This is how geometry changes in V1 lead. And ultimately, V1 you have the high RP, a classical pattern in this patient. Very good QRS, it was reduced right after the surgery. This is the first patient, LAO, proximal and distal ends. This is a rail plane. This is the placement of the lead subendocardium. And you see the thickness of the septum is quite big in that size of the localization. The pattern is quite nice, however it's just 40%. This is the potential of the left bundle. So you have a quite good QRS here. We are coming back to our measurements here. Same patient. OWD was given 65 seconds, now it's 0. It means that both the septum and the wall they're contracting simultaneously. Zero delay. This is the main thing to get to. When we're talking about proper resynchronization. The mechanical delay goes away, in which case we have a very hemodynamic. Some nice X-ray imagery shows depth penetration. How deep electron penetrates the septum. This is the spinal depth, about 14 millimeters. Patients take 6 septums. This is what we want, 14-ish millimeters. We see the around 8 millimeters proximal part. Patients without that thick septum, 8 millimeters is enough to stimulate the left ventricle. So these are the gold post-op cardiomyopathy, EKGs, very good stimulation threshold, 0.5 volts, and you have a very good QRS, like classical patterns, QR in V1 lead and V5. Looks quite nicely. Intraoral echo, we are doing this for every patient. We advocate this method. This is the positioning of the electrodes supracardially. The main thing you want to get to, the main goal is this. Contraction of the left ventricle with these parameters. So opposite wall delay, OWD. So that's one of the examples of ours, inefficient stimulation that we upgraded. We threw in the electrodes into the septum and we got a very good stimulation results. 80 milliseconds is okay for patients with a lot of fibrotic changes, fibrotic lesions in the left ventricle. I'm also showing this to my students, to my doctors. This is very clearly seen. The stimulation, non-polar stimulation, and dramatic reduction of the QRS. 154 initially, 115 post-op. The same pattern, same good patterns. This is the yesterday's slides. Completely perfect QRS. This destruction of the heart conduction system in the patient with cardiomyopathy. This aortic valve surgery, history of that. So we didn't change the geometry of left ventricle, but we got the QRS. Well, the QRS remained more or less the same, around 106 milliseconds. But the STR is now only 53 milliseconds, V1. So if you're looking at that, Yuri, your time is up. Okay, thank you. So what do we ultimately get to? This is the mechanic systole of the left ventricle before and after the resynchronization. And this is the main thing again, this contractility of the left ventricle, how much it gets better. The amplitude of LV contractility is improving so nicely. So these are the surgeries. I guess I might as well scroll down to my conclusions. This kind of therapy is quite efficient in terms of heart failure treatment. The biventricular pacing is improving the endpoints by 2 times. So the final slide with the conclusions, if my time is up, it's up. Now with the stimulation of technologies, with the advent of technologies for stimulating the His bundle, the left branch of the His bundle, constant electrical stimulation for bradycardia and disturbances of interventricular conduction becomes more and more physiological. And in a certain category of patients, it's perfect. So I was supposed to forget the classical tri-chamber pacing. Well, not really. We're supposed to remember about it. We don't have to disregard it. Thank you very much for your attention. Thank you very much, esteemed Yuri, for your presentation, for your talk. I believe that today, during the day, as a co-host, you will have multiple opportunities to provide your contribution to the most relevant points in this topic, on this topic. CRT, resynchronizing therapy. Unfortunately, we're supposed to move on. We simply don't have the time for this for this slot. No time for the Q&A session. Just one kind reminder for the presenters. We have some time for the presentation and 5 minutes for the Q&A afterwards. Right now, I would like to bring up a video of the second webinar. Colleagues, the movie, please. Spinal cord neurostimulation. Thank you very much indeed for your attention. Indeed, neuromodulation, the most relevant matter of spinal cord neurostimulation, was the second webinar's highlight topic. The link below, please follow it to refresh your memory of this worthwhile webinar. At this point, esteemed colleagues, it is my huge pleasure to introduce Professor Luca Santini, Cardiovascular Division, Grassi Hospital, Roma, Italia. So, Luca,
hello, Andrey,
has been our good friend for many years now.
Yeah, thank you, and I am really happy to be among you, many friends, and really it's an honor for me to be part of this important meeting and to have the chance to say hello to all of you, and Professor Karpenko, and you, Andrey, and everybody. So thank you for the kind invitation. And thanks to Yuri for the wonderful translation job he's doing, really excellent.
Luca, could you please bring up your slides?
Yeah, of course. Thank you. So when you want, I can start.
Please start.
All right. So sorry for this technical inconvenience. And we have just heard how many progress we have done for the therapy of heart failure from Professor Karpenko. But it's not only a matter to give a therapy, we should also follow up our patients in order to assess that we are providing an improvement in their clinical status. And actually, in the last years, we have had a very dramatic improvements in terms of following up our patients. And as you know, heart failure is really a huge issue worldwide, affecting almost 26 million people. And we also know that it's affected by a very high mortality, which is up to 50% in 5 years. And many of these patients, moreover, are dying for sudden cardiac death, up to 7% of them. But the main problem maybe is the very high rate of rehospitalization, which may be also up to 44% in 1 year follow-up after discharge. And this means that we also have an economical issue, because so many hospitalization affects dramatically the budgets worldwide, and so expenses for heart failure care are really very high, and these numbers are going to increase due to progressive aging of our population. So what are the goals of heart failure management? We should reduce mortality. We should prevent hospital admission, which are so crucial, we have seen. And we should also take care of improve the clinical status and the quality of life of our patient. And in order to achieve these targets, we have many weapons in our pockets. We should go through an uptitration and an updated optimal medical therapy. We should insist and really be pushing our patient to have a correct lifestyle and diet, exercise, and so on. But we should also make and perform a routine and very strict monitoring and follow-up. And finally, we also have the huge help from the device therapy, which was really important in the last 20 years. If you can look at this slide with all the pipeline of the progress in terms of the heart failure therapy, you can see that the cornerstone for the therapy was maybe the last important cornerstone was the 2005, when the CRT therapy became a gold standard for the treatment of these patients. And actually, now there is also a lot of progress in terms of pharmacological research. And we know that device therapy was very effective in prevention sudden cardiac death, thanks to the ICD, that we can affect the symptoms and to reduce the morbidity and mortality thanks to the CRT. But we also we need now to implement the pharmacological therapy. And for example, if you see that the CRT provided a reduction of 36% in all-cause mortality in our patient with a reduced ejection fraction, we also can see that the sacubitril valsartan, which is one of the last drugs which have been proposed and implemented in the guidelines for the heart failure treatment, provide an adding value of reduction in terms of all-cause mortality of 38%. So we are really focusing on a lot of news in terms of treating our patient. But there are also many other promising drugs which are under study now. And sometimes it's also a matter of luck, and there is a sort of serendipity-based medicine. A typical example is about the gliflozin. You know, gliflozin are born as drugs for the diabetes. They are able to inhibit the SGL transporter receptor, and in many trials at the beginning, they were found to be very effective also in treating the heart failure patients. The last trial, the Emperor trial, showed incredible results in terms of hard endpoint, reducing the cardiovascular death and hospitalization for heart failure. And very soon, it's already in the guidelines for patient with diabetes and heart failure, but very soon I believe that the European Association will include this family of drugs also for the treatment of heart failure patients without diabetes. So it's one of these important points in the history of medicine where you are looking for something and you find something different that is surprising you. So if you look at this flow, it's the typical flow of an heart failure patient, which have at the beginning plateau phases where the sickness is stable, but then dramatically we face with very fast and frequent acute decompensation. And if we want to change and to flat this curve, the only way is to provide to our patient a very strict follow-up in order to prevent acute decompensation events, which are the main issue we are dealing with in treating our heart failure patients. But the only way to do that, to achieve this target, is to make a lot of resource, to use a lot of resource, and this is not very easy, especially in this moment where we are facing with a dramatic mismatch between the healthcare workforce and the increase of the chronic global disease burden. So we need a help also because the taxonomy of disease is changing. We are not going to analyze the cardiovascular pathologies only as a static condition, but they are more and more dynamic and highly dimensional. We need to take into account imaging data, biochemical data, clinical data. So we need really a huge effort to be effective in treating this patient. We need our help. I was saying that is also a revolution, and which is called e-health, because alone we are not able to get it. We know that now we can record every single clinical parameter. There are plenty and thousands of different sensors, and majority of them are already wearables and will be invisible very soon. Everything that can be digitalized will be digitalized. And if you ask me what about what is not going to be digitalized, I'm sure that very soon we will be able to digitalize also this kind of data. Actually, as a cardiac pacing physician, we have already been a pioneer for telemedicine because we started at the beginning of 2000s using the remote monitoring of our implantable device. And since the beginning, we understood that the main issue of the remote monitoring was the ability to detect clinical events. The majority, almost 90% of the data we were collecting by our these implantable devices were clinical and not only related to the devices. So we shifted very soon from a simple remote device monitoring to a full and complete remote patient management. And as you know, now remote monitoring of our implantable device is a gold standard, is included in the guidelines as a class 1 indication. But if you see, this is especially true for patients with atrial fibrillation, while for patients with heart failure, we have just a class 2 indication in the guidelines. Why this difference between these two, the twin pandemics of our age? Actually, because all the trials which were comparing a standard follow-up of our patient with implantable device with our remote monitoring of this device were disappointing or provided natural results, but in time, which was the only trial showing a reduction in mortality. And there are several reasons to explain these disappointing results. The first is the kind of data we were going to analyze. Second is the kind of technology we were using, which are not all the same. And finally, also the organizational model, which is a very key point to provide a correct and effective remote monitoring of our patients. As you can see, the first trial, they were all focusing on the detecting of the acute decompensation through the detecting of the thoracic impedance decrease. But focusing only on this single parameter provided a neutral or negative clinical outcome, while we know, as the guidelines tell us, that we should go through a multi-parameter monitoring based on ICD. That's the target, and that's a very clear example that can explain why. If you look at these two graphics, you will see that both of them are showing a decrease in thoracic impedance. So patient A and patient B, both are going through an acute heart failure event? Not at all. If we can look at the full picture, we can see that only the patient A is going through a true acute decompensation, because all the other parameters are coherent with the decrease of the thoracic impedance, while on the patient B, that was the only data, while the others were stable. So maybe this was an artifact or a confounding data, which is very common in our experience, focusing only on the thoracic impedance decrease. So this is just to tell that we should have a complete picture of our clinical, of the clinical status of our patients. So we need to collect contemporaneously many data. But we are able to collect data, but this doesn't mean that we are able to use them, because it's very complex to put together all this information to have a final information which is also useful for us and for our patient. And we need an help again, because we are not able to implement and to integrate all this information in a very quick way. So we need the help of artificial intelligence, which are really a breakthrough in our clinical practice, and they will be more and more in the next future. Machine learning are really, I believe, the base for the new technologies in terms of follow-up for this chronic disease. And we have an example of this applied in the clinical practice thanks to a new algorithm which is really very useful and promising, which is called ArtLogic, and which actually do exactly what we are used to do when we visit an heart failure patient in our office. What we do, we visit him listening to heart sounds. We see if there is an S3 tone, for example. We ask him if he breathes in correctly, or if he has dyspnea, how many pillows he uses at night, if he can make effort without being dyspnoic, if he feels tired, if he is gaining weight. So all this clinical assessment evaluation we are used to do in an office, it's now possible to perform automatically by the device, which is able to record all this information and put together, is able to record the heart sounds, measuring the decrease of S1 and if there is an S3, of course, we can measure the thoracic impedance, the rate and the volume of respiration, the activity of the patient, the mean heart rate in the night. And so combining all these parameters in a simple index, we can have an alert which is able to advise us that the patient is moving fast through an acute decompensation. This is the ArtLogic, which has been studied in the MultiSense trial and not randomized and international trial, which provided a very high sensitivity of this algorithm, up to 70%, and which showed to be able to advise, to give an alert about an acute decompensation up to 34 days before the event finally occur. So really a huge help for us. And you can see that in the multivariate analysis, the ArtLogic in this MultiSense trial was the clinical variable which correlate much better with the clinical event compared to all the other factors, like including NT-proBNP, for instance. And this is a sub-analysis by Gardner, which is showing that this index is really strong in stratifying patients, because when patients are in out of alert state, they have a very, very low percentage of events per year. That means that we could dedicate our resource and our main efforts only to patients in alert status, and this is very important when we are dealing with a matter and an issue like the lack of adequate resource we can use. And another important issue is that ArtLogic showed to perform in stratifying our patient really great, even better than NT-proBNP. You can see that when we have a low NT-proBNP, but we are in ArtLogic alert status, we have a significant rate of events, while when we, on the opposite, we are out of ArtLogic alert, even if we have a high NT-proBNP, the alerts are really low. And of course, when we have both the indicators, NT-proBNP high, and also we are in ArtLogic alert status, the rate of events is higher. So this was just the results of a trial, but we also now have experience from real-world data, because we have been in Europe. There are several centers, and we joined together, and we were the early adopters of this algorithm, and we performed first a retrospective phase and then an active phase. The retrospective phase was completely blinded, because we enabled the algorithm, and which is available on the remote monitoring platform, the Latitude platform of the Boston Scientific, and we were able to correlate this with all the clinical events which have been occurred in the previous months. And we were able to, for instance, to find that many of these, the clinical events that have occurred, could have been detected by the algorithm, which were giving and providing an alert every time that then the patient, before the patient went to the hospital. But this is just an example to show how it works. This was a patient, and you can see on the graphic that all this increasing in the curve, it's when we overcome the threshold, the art logic give us an alert, and every time the algorithm gave an alert, the patient actually a few days later was hospitalized for an acute decompensation event. So in a blinded pattern fashion, we could actually provide the utility and the efficacy of this algorithm. And we also confirmed the data from the multisense trial in terms of this incredible anticipation of the detection that was up to 38 days for the hospitalization. We could show that the majority of the alerts were correlated to a discontinuation or reduction of prescribed heart failure therapy. And this is a very important point, because this taught us that in many cases the problem is that the patient, the adherence of the therapy to the therapy by the patient, which stop, for example, the diuretics or reduce the dosage, and so they undergo to an acute decompensation. We also confirm the importance of the heart sounds, which really are a very strong predictor of acute decompensation event, because in 100% of warnings, there was an involvement of the increase of S3 or decrease of S1. And so this is very important, because when we are looking at an alert which is triggered by the heart sounds, we are sure that there is an heart failure event. If we have not an heart sounds involvement, maybe we could also deal with a respiratory problem, and we could stratify our patient better. But we also showed in this other study that the heart sounds measurements provided by the algorithm was really effective and correlate very well with the echocardiographic measurements of the diastolic and systolic function. So again, assessing very importantly the efficacy and the ability of this algorithm to correlate with the physiology of our heart. But we went more forward, and we also studied, and we still are doing this algorithm in an active phase. That means that we are trying to understand how it can help us in the management of our patient. And this is just the first publication we got together with a multi-center group in Italy, where we were able to evaluate the number of alerts deemed clinically meaningful and the proportion of new clinical events which were signaled by the alerts, and the proportion of them which were actionable alerts. And we also compared a strategy of alert-based follow-up with a strategy of scheduled monthly remote transmission. And we could evaluate so the association between the alert condition and signs and symptoms of worsening heart failure. And we found again that the algorithm performed very well. Many of the events were correlated to symptoms or signs or clinical deterioration. Again, discontinuation or reduction of the prescribed heart failure therapy, or for example, decline and reduction of CRT percentage in biventricular defibrillator recipients. And also we could see that the action we could take following the alert, they were very effective, especially the diuretic dosage increase, because again, we found that many times the problem was the reduction of the interruption of the diuretic therapy. We could also undergo to cardioversion for new onset atrial fibrillation, or reprogramming of the device if we needed to optimize the CRT programming. So a really great help. And this is just an example. Again, you can see the red line is when the patient interrupt, in this case, the diuretic therapy. After a few days, the curve start to increase, overcame the threshold, and we had heart logic alert, which is the blue line. We were able, so remotely, to call the patient and to increase the diuretic dosage again, and after that the carb started to decrease, and we finally reached a stability for this patient. So this is just an example to show how we can have a clinical true impact in our monitoring in our patients. And we also found in this experience that we don't need to schedule every month remote follow-up for this patient. We can, it's so trustable that we can go to adoption of a heart logic alert-based management strategy. That means just follow the alert patient, and we can follow the patient that are in out alert status only maybe once per year. We don't need to follow up them more often because the alert performs so well that we can trust it. That's another important message in terms of organizational model. Of course, the final word will arrive from the randomized trial, which is under evaluation. It will be complete in the 2024, beginning 2025. The first phase is the not randomized, which is very similar to our first experience, but the most important in the phase 2, which will be randomized, comparing the remote patient management using heart-logic alerts to drive heart failure care compared to standard remote patient management without heart-logic alerts. Also, other companies are fastly moving to implement in their device and remote monitoring platforms such algorithms, and there are already some first experiences. So this means that in the future, this kind of monitoring our patient will be really the standard. And what we learn from this first experience is also that when we talk about heart failure patients, when the patients say, I feel healthy, it doesn't mean that is really healthy, because we should we should give our intervention when before that there is a clinical significant deterioration, and this is a matter of time, and this is not very easy because, as you can read, both patient and physician dealing with heart failure have a propensity to underestimate when they are stable. When the patient is stable, maybe in NIA class 1 or 2, we are prone to think that everything is going fine and we don't need to implement or to update our therapy, for example. And this is not true, because when the perception is misleading when we are in a class 2 NIA phase, of course, because yes, we have not so many symptoms, but still the structural disease is moving fast. We have the remodeling of the heart. And so this is the moment where we should give the patient the best therapy we can. And this is not very common, because there is this trend to be scared of the potential side effects of optimized complete drug therapy. Sometimes we are not going to neither give the electrical therapy when, despite it could be indicated, because the patient is in NIA class 2, and we wait maybe that is going to a class NIA 3. So we should be more earlier in giving the best therapy we can to our patient, because also in the beginning of the heart failure stage, we have already electrical instability, and there is a continuous progression of the disease. And if we compare the American Heart Association classification of the heart failure, which is taking into account the structural alteration, with the clinical classification, the New York Heart Association class, we can see that we are in class 1, for example. We already have a structural heart disease. Also, if we have no signs or symptoms of heart failure. So already here, we should start to give the higher and more aggressive therapy to our patient. This is the only way to avoid progression to the further stage. And we, as you know, let's hope that now it's over, but we went through a really dramatic crisis with the last pandemic. And this was also an opportunity from another point of view to implement finally the telemedicine and telemonitoring for our patients. All the main scientific association suggested and provided documents suggesting to implement the remote monitoring of patient with implantable device in the clinical practice. And this was, of course, pushed by the crisis of the pandemic, but is something that really it was not homogeneous worldwide, but now it should be and become finally, definitely, the gold standard. It's a huge challenge because, as you have seen, to monitor all these patients remotely doesn't mean that we have less work. Maybe sometimes it means that if we have even much more work, but it's also a huge opportunity. And moreover, in the future, when we'll be able to have many other data to collect. For example, finally, we will have also hemodynamic status evaluation, for example, with CardioMEMS. We will have the ability very soon to have also the chance to remotely detect some problem by blood test data or many other different information. So we need to analyze all this huge amount and volume of data, but we need to do this very quickly with a very fast way. And this is a really big challenge. And there are now artificial intelligence, as I said before, that really are fasting and very quickly implementing in our clinical practice. There are some apps, some of the algorithms which are able to detect, for example, an heart failure decompensation status only through the analysis of voice. There are many other examples that are really at the beginning of a new era. And maybe this is science fiction, maybe not, I don't know, but it's foreseen that in few years to help us and our neural ability to analyze very fast all this information, we will are going to send nanorobots into the brain via capillaries, which will provide a full implementation and immersion in virtual reality with our nervous system. So I don't know if this is true, but it's not so far from the reality, in my opinion. And finally, this is very amazing and fascinating, but we should never forget that we can use all the technology we want, but we should always follow our clinical judgment, which is the polar star for our profession. So this way to put all the information in a linear, logical, and sequential thinking, which is the base for our for being doctors, true doctors. Otherwise, we will make the end of Charlie Chaplin in modern times, where he is completely fed by the machine and is not able to do anything else that open his mouth. Thank you for your attention.
Thank you very much. Grazie mille, dear Luca, for your wonderful presentation. Great talk indeed. Dear colleagues, whoever wishes to join me in the studio, please, now would be the time to ask the questions to Professor Santini and Raini. Tech people, can we please bring up the screens? Yes, Luca is right there. Огромное спасибо, Luca. Thank you very much for the talk. Okay, so what are the questions, dear colleagues? Are there any questions? If I may, yes. Yes, of course, Yuri. Okay. Thank you for the amazing talk, amazing overview indeed. From the viewpoint of practical medicine, I knew that there were cutaneous impedance measurements, right, to detect worsening of HF. These are more less advanced, less sophisticated devices that don't have to be implanted. So cutaneous devices, what is your opinion, dear Luca? The worsening of HF diagnosing by skin impedance.
That's a good question, because we can share the heart failure population between those which have already implantable device, but this is just the top of the iceberg, and there are many other patients which are not implantable devices, and they are not going to implant them. And there is a telemedicine also for them, which is very fasting approaching in the clinical practice. And as you say, there are many sensors, cutaneous sensors, which are able, and they, of course, we need to try to have experience to establish if they really works. But I believe, I agree with you that this will be the future. And in the next future, maybe we also through the loop recorder, many of them will be able to be enabled with these algorithms. For example, heart logic and the heart sounds detection, it will be for surely available also on the new loop recorder, because the S3 and S1 detection is performed by the generator through the accelerometers, not by the lead. So we don't need the lead to achieve this information. And that means that also just with the cutaneous device, we can have all the same information.
Thank you. Thank you. Any further questions, colleagues? Luca, one from me. Could you please tell me, what do you think? In which year, actually, what is the year when we will change the profile of our day-to-day operation? We will go completely remote. We will be able to put our trust completely into robots and big data. So your take on this?
Dear Andrey, I can't see in the glass bowl, of course, in the future. I can just have the same perception you have, that day by day, every day, we have a new way to use this technology. And collecting data is more and more important, but also we should learn the proper way to use this information. For example, let's talk about the opportunistic diagnosis of atrial fibrillation. Now, just with an Apple Watch or whatever, we can detect many often an asymptomatic atrial fibrillation. But once we know that there is an episode of atrial fibrillation, it doesn't mean that we already know how to treat this patient. Should we give him anticoagulation? Shouldn't we not give him? So it's not only a matter to collect data. What we need again to do is to have specific flowcharts and information to how to use this data. Otherwise, we can just collect many different kind of information. There are now tattoos which are able to give glycemic level day by day or whatever. And this is something that in the market, it's also a matter of a marketing issue, of course, that the company are pushing a lot with these new and incredible devices. But doesn't mean that all of them are reliable and that will have a clinical impact. Many of them will finally be only gadget. So the main critical point is always to have a severe and strict protocol to assess the utility of these algorithms. We need the demonstration by trial, by scientific approach, correct scientific approach, before implement this new technology in the clinical practice. But in the future, I think you are right, maybe not robot, but a cooperation with artificial intelligence and machine learning will be mandatory, and it will help to improve our clinical practice very much. But I believe that maybe this will become a real true, not so far, but not before 10 years.
Luca, thank you. In this regard, could you please tell us, so all of us understand how limited we are in, say, training of doctors, in challenges with training, postgraduate training of doctors. There are challenges in medicine, in particularly in intervention cardiology, in surgery. So if we're putting up a barrier, say a decade, right, a decade from now, as an obvious one, as an apparent one, for the new changes to bring to come into life, and at the same time, would not envisage any fundamental changes. We do not envisage any fundamental changes in the curriculum, in the training of postgraduate training of doctors. So do you see a discrepancy there? Is that going to be a colossal barrier? Or first of all, we should be thinking about changing the curricula first, the postgraduate curricula. And then only secondly, or secondary to that, that step, once we've improved the training, it will help us get to the new prospects, new horizons. Is my question clear?
I believe so, yes, and I agree with you. This is a open point, but we can see, for example, I think it's experience of all of us when we work in the hospital, there are a huge gap between the different generation. Just for example, with the clinical documents, you can see the youngers, which are much more prone to record everything digital and to collect the information. But while on the other side, the older generation are really still love to writing by hand in the documents and so on. So this is just a stupid example, but you are right. We need to also prepare the young physician from the beginning to this new technology, disruptment, which will be in the next future. We need to be digital. We already are digital in our daily life for social, for communicating, and this is what we are doing now. Is the typical example. Who could think that 2 years ago, just 2 years ago, that we could make a meeting or a wonderful webinar like this remotely with people from Italy, Russia, Ukraine, all over the world. So that's the incredible speed of the future on technology. The real issue is that I'm scared that the speed of the technological evolution is overcoming the speed of human evolution. Every generation has something more, and this is, we know since the evolution theory of Darwin, but I'm scared that now the technological evolution is much faster than the ability of a human nature to adapt to this technology, and this push us and give us a lot of stress. And maybe this is one of the issues and the difficulties that we are living in these times. I don't know if it's clear, but this is the challenge we have to win. And artificial intelligence and digital world, it should be a help for this, not create more problems. That's the way, the rule that we should always follow. And to do that, we need, as you said, to start since the beginning. In the postgraduate phase, we should pay attention to the education about technological and the digital techniques. And it doesn't mean that we are not a physician anymore and become engineer, not at all. As I said, and the last slide of my presentation was focusing on the importance of our clinical judgment. Nothing can replace this. So we should always have this polar star in our mind, very clear. But we need to use the technology. Otherwise, we won't be able to increase and to grow up in our clinical practice.
Right. I hope that this does not mean we will not get to see each other in Rome, right? You mentioned you don't have to travel these days. What about the next conference?
Yeah, we hope that very soon we can. I am really starving to give a hug and to all of you, and I'm really tired to be just in front of a screen. And we made our last congress remotely, as you know, but we hope that in 2 years, because we do it every 2 years, we can again go back to have a dinner together with the carbonara in Rome with all of you.
Grazie mille, dear Luca. Dear colleagues, I would like to move forward and just a brief reminder from our third webinar. Comprehensive treatment of patients after RF ablation. Thank you very much. Moving on. It is my huge pleasure to introduce the next speaker, PhD in medicine, Viktoriya Skidan. We've been friends for a long time with her. She represents consultancy and diagnostic department of the Federal Center for Cardiovascular Surgery from Khabarovsk, from Russia. Obviously, our geography is expanding. We're going east. It is my pleasure to give the floor to you, Viktoriya. The talk will be, as per the previous announcements, isolated hypoplasia of the left ventricle apex as a rare new form of cardiomyopathy, diagnostic criteria and interventional treatment. Could you go full screen? Andrey, I wish to thank you for the opportunity to popularize. Could you please go full screen? Trying. Just 1 second. Правее кнопочка, там такой флипчарт, видите? Вот 4-я кнопочка внизу, рядом с ползунком. Вот это. Right, going full screen.
Глубоко уважаемые коллеги, мне бы хотелось сегодня представить вам крайне редкую патологию.
Esteemed colleagues, I wish to show this quite rare pathology, restricted hypoplasia of LV apex. It was first classified as congenital cardiomyopathy in Cleveland Clinic, US in 2004. MRI findings in 3 patients were analyzed. Magnetic resonance imaging was analyzed, and similar anatomy changes have been detected, have been identified in these 3 patients. If you haven't seen such a patient in your clinical practice, you wouldn't have known about this kind of cardiomyopathy. But this kind of congenital CMP got us very interested. We started perusing the literature. At this point, we have found 34 publications. We've even written a monograph. And I would like to share the outcomes of this work with you. Most importantly, Andrey gave me the opportunity to deliver this talk to a broad audience of cardiologists, doctors, arrhythmologists, because everyone can face it. So we've only seen 34 publications, 5 of them in Russian, the other 29 are in English. 48 cases of isolated hypoplasia of LV apex. So what is that? It's a rare congenital heart anomaly that now belongs to unclassified cardiomyopathies with restrictive type of hemodynamics, with spheric remodeling of left ventricle, with adipose tissue replacement. So the LV apex myocardium is replaced with adipose tissue. There are changes around papillary muscle and the betterment of the shape and function of the right ventricle, accompanied with clinical heart failure and heart rhythm disorders. From the viewpoint of epidemiology, the pathology has been described everywhere except for Africa. I guess we know why. We can guess why. True prevalence and the incidence is not currently known. These are definitely not all the patients with this pathology in years. However, these are the cases that have been identified and described by experts in literature. These are the main findings, the main works from 2004 to 2019. So different ages, different genders as well, different sexes. In China, from the viewpoint of geography and epidemiology, 8 patients, well, because of the vast nature of the country, 6 cases in Russia and the US, European Union, another 6 cases, UK and Commonwealth, 7 cases, and sporadic cases of Korea and Iran. Mean age of these patients is around 29 years. The age ranges from 3 months to 66 years. Etiologically and pathogenetically, we came to the conclusion that the gene-determined hypothesis can be, well, there could be 2 issues. First is the breakdown of genesis, of morphogenesis of the heart in embryogenesis in the early fetal period, or it could be a mutation of the lemmin gene. The lamins are structural proteins, many known cardiomyopathies, autoimmune diseases. The nuclear lamina provides the strength for the nuclear envelope and the organization of nuclear pores. It resists deformation forces and protects chromatin from physical damage. Italian researchers in their article, they've analyzed the analysis of lamin gene in a family with 2 cases of isolated LV apex hypoplasia. The congenital nature is not even up for debate because the signs are detected in MRI. And in one patient, it was ultrasound, antenatally 3 months old. Standard obstetric screening came up with that. This pathology is virtually symptom-free in children and teenagers, and it's clear why. Because the LV apex is replaced with fatty tissue, with adipose tissue. If we imagine the morphology and the dynamic of contractility of the LV, you know, the longitudinal structure, the deformation, the deformity of the tissue radially. The radial is clockwise and counterclockwise, radial deformation. In children, unlike in adults, it is counterclockwise. So in this case, as the patients grow older, the apex is not contracted because it's no longer cardiomyocytes, it's adipose tissue, it's fat. This is when we see the manifestation of chronic heart failure. In adults, it's congestive heart failure, various heart classes, NYHA 1 through 4, all kinds, systolic dysfunction, mostly restrictive type, decompensation with biventricular chronic heart failure, high lung hypertension, and syncope. One fatal outcome has been described in 19-year-old from Italy. That adolescent died after exercise, after uncontrolled hypertension, pulmonary hypertension. Supraventricular tachycardia, atrial fibrillation, ventricular tachycardia with fatal complications are rhythm disorders, up to pulmonary edema and ventricular fibrillation. That single case presented with that, single case described, that Italian adolescent. Now, the combination of this pathology with congenital disorders, these patients are free from coronary artery damage. There is no atresia of aortic or mitral valve. There is no intraventricular disorders. 30% of patients present with open arterial flow, complete transposition of AV valves, aortic stenosis and pulmonary artery stenosis, as well as concomitant anomalies, the obstruction of the left ventricle outflow, diverticuli of LV, and neocompact LV myocardium, non-compact LV myocardium, which also causes problems with heart rhythm and detecting disorders. In the clinical picture, if you analyze all the articles published to date, the ones that are available on Medline at least, it was found that symptom-free progression is seen in around 70% of kids. Heart failure class 1 through 3 NYHA was found in 73%. The syndrome, the small circle overload syndrome with high pulmonary hypertension, seen in 20% of cases. Arrhythmic syndrome in almost half. Atrial fibrillation, 1 in 4. AV conduction abnormalities, 20% of observations. VT and VF as the cause of death are just sporadic cases. To diagnose isolated hypoplasia of LV apex, MRI plays a key role. And this imaging technology was the first one, was the one used to identify first cases. However, ultrasound is also important. Its importance, its relevance has been confirmed later. The affordability and feasibility of echo is clearly seen in first cases. This can be seen in a conventional cardiography workup. This was the case with me. When the patient walked in from the reception area to the ultrasound doctor, I found this patient like that, an ultrasound. So what kind of hypoplasia in the LV apex do we see? Spherical shape, missing pinnacle. There is a intraventricular septum is pumped up. It's tending to the right, like an aneurysm, but its kinesis is preserved. Another sign that our American colleagues have described in Cleveland, Monica Fernandez-Valls, she was a fellow in the MRI department, Spanish cardiologist. Her observations were supported by the clinical, by the professors in Cleveland. Basically, Monica Fernandez-Valls is the pioneer. She's the first author of the paper that described those three initial cases. So first of all is the adipose tissue replacing the LV apex. The myocardium is replaced by fat. Ultrasound is not always detected. It can be visualized as a hyperechoic inclusion or a hyperechoic area of akinesis in the area of LV apex of an oval or triangular shape. On MRI, it's in fat set mode. These areas are hypointense. The third sign is a papillary muscle apparatus. The papillary muscles of mitral valve that are supporting the mitral valve, they're creating the structure in the left ventricle. They are on this flattened apex, flattened LV apex. Subvalvular structures can be missing, they may differ. The papillary muscle length is satisfactory or shortened. The heads of papillary muscles can be hypoplastic and the chordae are elongated. You see the ultrasound presenting with these flattened papillary muscles, PMs. The fourth sign that the American colleagues looked at was the changes on the right ventricle side. It's elongated, it's banana-shaped, banana-like. There is a wraparound of the hypoplastic apex. There is this wrapping around in the hypoplastic LV apex. We know the RV hypoplasia with adipose tissue replaces in the anterior wall, in the lateral wall, with the coming rhythms, ventricular tachycardia. Something similar can be seen in the left ventricle. Maybe it's similar. At this point, this pathology is not classified. Its prognosis is unknown. Medical follow-up is definitely required. For formation of registers is required. Development of standards for medical treatment, drug treatment. Development of strategy for surgical correction of CHF and rhythm disturbances. Evaluation of the possibility terminal cases of heart transplantation. And the place of this nosology in the cardiomyopathy classification needs to be determined. We would like to present our case. We have been following up a patient for 4 years. It's a 30-year-old male. He came in, the initial presentation was at the age of 32 with pronounced AF, CHF, Borg test significant, polycerasitis, heart rhythm, atrial fibrillation, refractory to standard drug therapy. CHF functional class 3, New York Heart Association classification. We prescribed the methodology of radiofrequency ablation of the pulmonary vein ostia. The methodology has already been determined. The patient came in, they showed up at the office. And basically, we thought it's aplasia, but internet helped us find the description of this pathology. Our patients came with all the classical shapes, spherical LV shape, cutoff flat on top. Also, the ejection fraction was significantly worse than 32%. the basal apical size of the LV was 43 millimeters. It's very, very small. The swelling of the interventricular septum to the right, same clinical finding. MRI confirmed. Papillary muscles were attached to the flattened top of the left ventricle. There was abnormalities of the posterior papillary muscle. The elongated right ventricle was kind of sweeping around the contour of the apex of the LV. The ejection fraction of the right ventricle also suggested very low figures. Right ventricular insufficiency was also seen in 3D ultrasound. Additional analysis methodologies, trivial additional signs, trivial MR, trivial tricuspidal regurgitation, trabecularity in LV walls. These are the pictures indicative for the LV shape changes, LV shape malformations. Non-compact myocardium of the LV apex, we suspected that, it was confirmed on MRI. Polypositionally, we did the ultrasound. Through the esophagus, we saw the papillary muscles that were attached to the flattened top of the LV apex. And we saw the issues with the valve, the aortic valve without dysfunction. It was displayed into the non-orthogonal plane. Analyzed the ejection fraction, typical picture of akinesis in the apical cap zone and the low ejection fraction. Virtually the same goes for the left ventricle on MRI. Our MRI colleagues have come up with the same findings, shortening of the LV, non-compact myocardium in the anterior and lateral segments. Treatment strategy, given Holter monitoring, there was paroxysm, ventricular tachycardia unstable. We decided to go with the ICD, implantation at the first stage. Given the recommendations, indications, ventricular tachyarrhythmia, low ejection fraction, we went for it. RFA was done 1 month afterward with CARTO system, radio frequency ablation. All pulmonary veins were isolated. Diuretics, anticoagulants have been added. Repolarization inhibitors, because before the therapy, well, the patient had no history of treatment. When we published our article in the cardiology journal, there was a lot of peer review questions. We got the question why the implantation was done of the ICD and not the RFA. Why did it come as stage 1, not stage 2? Why not switched places? Well, it's from bad to good. The implanted lead in the apex of the right ventricle that was coming around to the top, to the apex of the left ventricle, it caused the repolarization to change. And it caused the contractility of the left ventricle. 3 days after the implantation of that ICD, we got the ejection fraction up to 50, which was completely amazing. It was completely unclear at this initially why that outcome was reached. And then we assessed it as a very good result and the right decision that we've made to go with the ICD as the first stage. After RFA, 1 month on, CARTO 3 system, PV isolation, we restored sinus rhythm in the patient, and the ejection fraction went up to 58–59%. The size of the left ventricle also came down. It got smaller. The right atrium got smaller, but the left atrium was quite big. It stayed quite big. 62 millimeters indexed area. So essentially, this is dilation, and quite significant one. So there was a question how much time we can maintain this patient on sinus rhythm. In 6 to 12 months of follow-up, it turned out that there are no problems there. The sinus rhythm is perfect, great tolerance to physical exercise. Borg test 650 meters in 6 minutes. Modified scale, modified Borg scale. You see even visually the ultrasounds. We're not ultrasound diagnosticians, but we can see how well the ICD helps contract the left ventricle. Mitral, tricuspidal regurgitation went down. The ejection fraction is 54, very good stroke volume. And we see the reduction of the akinesia zone in the left cap of the ventricle. So basically, we have done the right thing prescribing this treatment. There was objective proof of that. So restrictive changes of diastolic functions, tissue Doppler confirmed it. It stayed. That pathology stayed. Quite high pulmonary hypertension up to degree 2, second degree. We started following up on the patient. 2-year follow-up helped us show sinus rhythm is there, the chambers of the heart are not changing. The heart model on picoseparators, you see the LV and LA. The LA is 100 milliliters, normalized to area 54.2 milliliters per kilogram per square meter. Basically, this patient will have a hard time maintaining sinus rhythm. And we got the confirmation by the CareLink system. When the endogram was recorded, was ventricular tachycardia with subsequent rhythm restoration. There was a false shock we saw because of the paroxysm of AF up to 300 BPM ventricular beats with subsequent sinus rhythm restoration. Such episodes were seen several times throughout the year. However, sinus rhythm was still there. 3rd year of follow-up, same story. And only after almost 4 years, the sinus rhythm got disrupted. So there were again paroxysmal paroxysms of atrial fibrillation. Then there was persistent AF. This is why we went for the repeated surgery, repeated RFA. Again, PV isolation. And the mitral isthmus and the LV apex was done in April this year, literally a month ago. So I believe this case to be quite interesting. We should spread the word. We should promote these findings. Many of us will see this as clinicians, as diagnosticians. Many of us are likely to face this cardiomyopathy with 4 typical MRI and echo KG findings. Clinically adverse outcomes because of heart failure and LV-RV dysfunction, pulmonary hypertension, rhythm disturbances, and fatal VT. Medication and interventional treatments should be aimed to compensate the manifestations of CHF and prevent cardiac arrhythmias. Thank you very much for your attention. Dear colleagues, thank you very much for your attention. I'm sharing my screen, right? Yes, thank you so much. Thank you, Victoria. And dear colleagues, any questions to Victoria, please fire away. Surgical people, where you at? A rare type of cardiomyopathy, a rare type of CMP. And if you can recall, dear colleagues, we had a webinar, dedicated webinar on that. We will remember it today. It was dedicated to cardiomyopathies. So any questions? Victoria, may I ask you a question? I didn't quite get the mechanism of LV improvement after ICD implantation. Can you comment on that once again?
И сразу вопрос, а назначали ли вы этому пациенту с 17-го года антикоагулянты? Да, он получает. То есть он, нет, вот сейчас-то я понимаю, а тогда?
No, now I understand, but back then, what about back then? No. So now he's on liquids, 2.5 grams twice a day, standard dosage. Initially, no, it wasn't the case. We were managing him with heart failure, paroxysmal atrial fibrillation, then we threw anticoagulant on top. Any further questions? I just wished to show that picture with a banana-like RV apex wrapping around the LV apex. Yeah, I remember it. When in correspondence with our English peer who was reviewing our article, our article about this patient was published in the European case report, European Heart Journal. Case report was there. There was a lengthy discussion, and it basically got us all to conclude that most likely the conductivity of the agitation, somehow the lead affected the apex of the LV, and it kind of affected the ejection fraction, improved it. Thank you. Any further questions? I don't see any. Thank you very much indeed, Victoria. I hope you will stay on. You will not abandon us. I'm very happy that we've been able to expand the geography of our speakers. We love our centers. We've been there multiple times. Our best regards to all our friends there. Thank you. We love you guys too. Okay, thank you. Big hello to our colleagues. Hopefully you'll be able to take part in the discussion during the day. It is my pleasure to remind to all those attending and to all those watching it in the recording, just a small highlight video of the 4th webinar. Could you please launch that video? Irina, it is a pleasure to welcome you again. You come here time and time again. There's no way of replacing you. You are our friend, and you're always there for all our webinars. My cordial gratitude from the bottom of my heart for your willingness to be a speaker in our webinars. You're a great expert. You're there again. You're here with us again. The format is quite tough. It's very difficult to build the logical canvas of information representation. So we're doing flashbacks. We're doing highlights of the previous events. So now you have the floor. COVID-19 and atrial fibrillation. Personalized approach when prescribing anticoagulant therapy. So is personalized approach possible? Thank you very much, Andrey. I sincerely thank you for the invitation. It is a great honor for me to participate in EVRA webinars. Now, in my presentation title, I asked this question: is personalized approach of anticoagulant therapy possible? In some cases, I asked this question broader to myself: can you manage a patient with COVID-19 and AF without personalizing the anticoagulation therapy? Well, this combination of diseases is a big issue. Well, I'm supposed to show this disclosure. My presentation is supported by Boehringer Ingelheim, so the bigatran will be the highlight of my presentation in AF plus COVID. So what is the issue? AF is a frequent disease that is seen in patients with coronavirus. It's basically, it's very difficult to say what came first. On the one hand, AF is in the top 10 of comorbidities of COVID-19. It's ranking 7th. This is the American data. And there are multiple publications, there are multiple considerations, contemplations on this topic, pathophysiological explanations as to why patients with AF tend to contract COVID more often. Well, ACE2 inhibitor, you know, this second type, it's higher expression. It is higher in patients with atrial fibrillation, which is basically used by the cells to get the virus to get into the cells. Basically, AF causes people to fall down to come down with COVID more often, fall ill with COVID. AF can contribute to COVID. Patients with sepsis or ARDS, 1 in 3 or 1 in 4 patients had a recurrence of AF, of pre-existing AF, and in every 10th patient there was a de novo atrial fibrillation. That's a huge number of patients talking about here. AF was a meaningful issue because it was seen in 1/4 of patients that died because of COVID. Additionally, what else do we need to discuss here? It is known that the clinical infection is combined with coagulopathy. I will not stop on that too much because of the time limits. The Eurasia Arrhythmology Association was talking about this quite a lot. What do we need to remember? This pathogenesis is not completely decoded. It could be the direct cause, the coronavirus infection itself induces these changes. Or this could be immune thrombosis, the so-called immune thrombosis. So AF and COVID, this combination doesn't only come often, it's also a fatal combination. It's a fatal combo that is also coming with thromboembolism. AF per se is associated with pulmonary embolism, with the thromboembolism, with clots. COVID is increasing this even further. One group of patients with or without AF with COVID, D-dimer was high in patients with AF and COVID, C-reactive protein inflammation, myocardial damage troponin was elevated in patients with AF. So what will it show us? What does it show us? This immunothrombosis, these shifts because of the infection, they are provoking the disorders initially occurring in an AF patient. This causes the thromboembolic complications to go worse. Patients with roughly the same comorbidities, the same gravity of COVID, but with or without AF, that gives you a significantly different difference in occurrence of thrombotic complications. The CHED2 DS2, well, CHED-VASc score, it basically, this index, it didn't give the proper association of the risk with the death risk, and there was no risk with thromboembolic complications. The authors of that article make a very careful conclusion. CHED-VASc is insignificant because COVID heightens the thromboembolic complications risk so high that you don't have to bother with CHED-VASc. It's high without looking at it. Inflammatory shifts, inflammatory issues are very meaningful in forming the prothrombotic status of atrial fibrillation. We remember the levels of CRP, interleukin, the pro-inflammatory, or neutrophils v lymphocytes ratio. These markers were associated with left atrial appendage clots, with pulmonary embolism. In our works, we have shown multiple times the impact of genetic polymorphisms in the inflammation system, how they can affect the complications. It was more significant in patients that were not receiving AC, anticoagulation therapy. Yeah, there were differences in TNF-alpha genes polymorphisms, where anticoagulants contributed to, well, basically no anticoagulants, more thrombotic events. Anticoagulants help prevent it. The signal path of interleukin, when there is more soluble interleukin-6 receptor, this is meaningful. Pro-inflammatory infections, pro-inflammatory reactions are spiking up. Well, understanding this, there is a significant risk. There is a significant correlation between COVID, AF, and clotting. So AF alone was enough to contribute to higher risk, but COVID just made matters worse. AF and COVID-19. Patients with AF have a higher risk of contagion. At the same time, the coronavirus infection heightens the risk of AF reoccurrence. It increases the AF recurrence risk. Development of new arrhythmias, myocardial injury, fibrosis, hypoxemia, acute overload, cytokine storm. AF increases the risk of thromboembolic complications in patients with coronavirus infection, heart failure, respiratory failure, and death. COVID-19 increases the basic thromboembolic risk in AF patients. Chest VASC is a poor predictor for baseline thromboembolic risk in the patients with AF. Summarizing, as a clinical decision for myself when I'm looking at patients with AF and COVID, I make two main conclusions. First of all, it's a thorough atrial fibrillation screening. Arrhythmia detection changes antithrombotic treatment tactics big time. Sometimes it's personalized therapy. I will show it on a clinical case. When diagnosing AF, it's not exactly in line with the guidelines because, well, I believe it might affect the patient's prognosis. If you confirm the AF, efficient anticoagulant therapy must be prescribed to make sure that all the conditions are complied with, less mortality, lower mortality, fewer hospitalizations. Right, thorough screening of AF patients. What was I referring to? Getting back to the topic of our multiple webinars this year alone, Andrey, once again, thank you very much for running these. You have indeed selected the topics. You have indeed given us a platform for the experts to get together, to discuss the issues, to share opinions. So 2 webinars I can recall. One was CMP, the other one was dedicated to CMP, the other one was touching it, but not directly. There are doctors that trust in the atrial cardiomyopathy theory. I also believe this to be true. It's particularly relevant post-COVID. I believe that clinicians will agree with me there. We see a whole number of patients that live through COVID with all kinds of arrhythmias, not always AF, could be other SVTs or SV arrhythmias with higher left ventricle. Fibrosis cannot always be assessed in this routine clinical practice. So we see patients with recovered from COVID, patients with AF, with dysfunction, with supraventricular tachyarrhythmias, but not always diagnosed with AF. I believe that quite recently we've had a patient that came with a cardiometabolic stroke. All these changes, all these observations get us back to this theory. Why is cardiomyopathy happening? Why is there a clot in the left appendage? Let me recite the theory. the main factor, atrial fibrillation, is not there. The old arrhythmogenic therapy that all therapists, cardiologists know about, it's arrhythmia with a loss of atrial systole, disruption of hemodynamics, wall fibrosis, because the tension of the shift is changing. RAS system gets activated. The fibrosis of the atrial wall worsens the symptoms, and as an outcome, there is a left atrial appendage clot. So AF is just one link in the chain. There is one atrial disease. There are no criteria as to what this disease is, what kind of criteria to diagnose, what is the percentage of fibrosis, what is the systolic strain, what is the size of the LV to detect or to talk about cardiomyopathy. But formally, logical, we understand that there is some disease of the atrium. According to my clinical observations, there are quite a lot of those. And that atrial disease, whatever it is, it causes hemodynamic to change, maybe because of fibrosis, chronic inflammation, because of volemic stress, too much volume. Well, the atrial fibrillation could just be a mask of that atrial cardiomyopathy. Sometimes it can be masked with an SVT can be masking as that. And depending on the atrial cardiomyopathy clinical presentation, there could be either arrhythmical manifestations, AF, or the clots in the left appendage. So how this theory is interesting. There is research based on this theory. The use of this theory in patients, use of anticoagulants in patients with high BPM, high heart rate. We're looking forward to getting these clinical results. Me personally, I am fully advocate this theory. Just an example, a clinical case, 74-year-old female, February 2021, contracted COVID. Post-COVID, well, quite early, unstable heart pressure, arterial pressure, short episodes of speeding up heartbeat, issues in the area of the heart. She didn't go immediately for medical help. She turned several days on. On echo, you see hypertrophic issues in the myocardium. Ejection fraction is 48%. The left atrium is 49 millimeters. Volume index 34. Pulmonary hypertension. So severe patient. AH has grade 3 uncontrolled arterial hypertension. So we didn't find anything stroke-like. We put in the Holter monitoring. There is supraventricular tachycardia, and there is one issue of AF 5 seconds long. This is it. Well, this really looks like atrial fibrillation. However, the guidelines clearly tell us if we're recording a single channel EKG, we need 30 seconds. 30 seconds for AF for verification of the diagnosis. But nobody really knows what is the risk of a stroke in a patient with 5-second paroxysm. The 30 seconds are to convincingly, or to definitively categorize the AF as such. In this patient, we see the extension of the left ventricle. It's larger. There are also criteria that are pointing at atrial CMP, high stroke risk and clinical factors, ectopic ventricular activity. In this patient, I would use this consensus, European Heart Rhythm Association 2019. Frequent supraventricular ectopic activity. Basically, a brief incidence of AF that would not have caused the doctor to prescribe ACs. So basically, this could be a criterion. This kind of frequent supraventricular ectopic activity could be a criterion to prescribe anticoagulants. So this kind of activity can cause atrial fibrillation. It can migrate. It can be the first symptom that the atrium is sick, and the fibrillation will manifest. However, a silent AF is almost undetectable. A crystal trial, crystal AF, was a cryptogenic stroke. 3 years of follow-up after that. The loop registers, loop recorders with halters or with EKG only in 3%. So we're talking about different technologies and different incidence rates. Maybe our patient had a silent AF that we failed to detect, or maybe not. Maybe it's not true atrial fibrillation. It's just supraventricular activity that is screaming of the sick atrium. In my clinical practice, it's very difficult to clearly say to go with the AACs for such patient or not. But for patients post-COVID, for protocol of AF, we are advocating anticoagulants. It's not just preventative doses. It's in this situation, especially where there is suspicion on Holter monitoring, I give the full-fledged dose of anticoagulants as if the patient had an atrial fibrillation. Well, there was a bit of a poetic digression as a recollection of that webinar. So multiple times, for CMP, I've listened to it multiple times. Dear colleagues, I recommend it for everyone. It's a very important topic. So let me get back on track with my topic. So personalizing anticoagulants in AF and COVID. Well, okay, let's believe that we've confirmed the diagnosis. It causes no doubt. The AF is there. So there was an update. So the guidelines, the picture for anticoagulation therapy did not change since February. And if our patient has atrial fibrillation and is down with COVID, but is outpatiently treated, oral anticoagulants can be continued, or assess interdrug interactions. It's for remdesivir mostly. If your patient is on remdesivir, the patient is best switched to low molecular weight heparin when the remdesivir is taken. If it's dexamethasone, it's mandatory to switch the patient to low molecular weight heparin. Well, at home, dexamethasone is not really prescribed. Too often, remdesivir is more often the case. And in this situation, OX must be cancelled, low molecular weight heparin, LMWH, must be prescribed. So when the COVID drug is discontinued, the OX can be resumed in the recommended doses. So I suggest not to limit to that small spreadsheet. Our Liverpool colleagues are updating the coviddruginteractions.org website. Please hit it, check it once again. Sometimes the antibiotics that you might indicate for patients, the antivirals, they're not really prescribed for COVID, but they're not featured in the paradigm, but they might be on that website. If the patient is not, if the patient is hospitalized and there is paroxysm, in moderate severity, you can switch patient to, you can keep them on OX or switch them to LMWH. If there are issues with drug interactions, if the disease, if COVID is moderate, well, it's possible. If the disease is severe, the European, Russian, American recommendation, American guidelines, you name it, severe cause or severe case of COVID is the direct reason to switch from OX to low molecular weight heparin. Well, the therapy for severe COVID is tocilizumab, dexamethasone. It's per se, it's the reason to switch to low molecular weight heparin. Up to 50% of patients with COVID can experience acute kidney injury. And in this case, yeah, that's restoring anticoagulants must be prescribed. Concentration of direct OX in patients with COVID, there is one Italian trial on that. That is spring 2020. Severe patients hospitalized with coronavirus infection, they continued the intake of direct antiviral therapy. and the OX, 12 patients, there were data of OX concentration before the hospitalization, the blue bars, and the red bars is just 12 patients, right? And the red ones are post-hospitalization, direct OX, DOAC after hospitalization on COVID. Unacceptable titer increase, unacceptable level increase, going way out of the target range, unacceptably high. Literature analysis shows a number of publications about interleukins, interleukin 6, interleukin 1, TNF-alpha. They can affect the cytochrome activity. They mostly inhibit them. Interleukin 6, particularly, 3A4 is inhibiting that. It's inhibiting that. That metachrome is necessary to metabolize apixaban or rivaroxaban or edoxaban, but we don't have that. Out of the three direct products, only the Bigetran is free of that cytochrome 3A4. It's P3A4. It's not really engaged. So in meaningful elevations of cytokines, so we can see the pharmacokinetics of all exabans. Well, there will be an issue. Also, interdrug interactions, drug interactions, renal function impairment, low molecular weight heparin. This is the way to go. After discharge, yeah, go back to DOACs. If there was an AF and we had to cancel the DOAC, and then we cancel it for any other reason, how do we prescribe the OAC for the patient after discharge? I'm using this algorithm. This is not the last source of truth. This is indirect comparison of direct anticoagulants between themselves. If the stroke happens at the backdrop of intake of drugs, I use the Bigetran 150. Apixaban can be selected in full dose or the Bigetran 110 if there was a issue with bleeding. For bleeding, I'm going for the Bigetran or apixaban. Cranial hemorrhage, it's definitely the Bigetran because it has an antagonist. 80 plus patients, well, the first drug to spring into my mind will be apixaban, the Bigetran because of antagonist, chronic heart disease, chronic kidney disease, apixaban or rivaroxaban in lower dose. Class B renal failure, or the liver failure, the Bigetran or apixaban. Probe, well, sometimes it's difficult to prescribe this rivaroxaban. Tube feeding or significant swallowing disorders go for rivaroxaban or apixaban. There is no perfect anticoagulant that can save everyone and harm no one. This is my deep conviction. The personalized approach to choosing anticoagulant for each individual patient can increase the effectiveness and safety of treatment. That's my personal opinion. The Spanish colleagues ask the clinicians to look at the hepatotoxicity of DOACs in COVID-19. COVID-19 is hepatotoxic. Antiviral therapy is causing that. COVID-19 related and antiviral therapy is worsening the hepatic function. Renal function at discharge is also needs to be assessed. Patients with high hemorrhagic risk, high thrombogenicity of COVID-19, I mentioned that we need to choose in effect DOAC, preferably one intended to be taken twice a day because of hemorrhagic risk. And the presence of a specific antagonist can reduce the impact of underutilization of the healthcare system in the context of COVID-19 pandemic. You see the wording here, underuse or underutilization. The patients cannot always come to the hospital in due time because of the pandemic. In some cases, the patients come to us not with calculus cholecystitis, it's much worse. We don't have the time to wait for the DOAC to leave the system. we will need to go for the surgery, maintaining the right or observing the right requirements, observing the requirements. You see, there were no head-to-head comparisons for the Bigetran or other DOACs, but the Bigetran says better features in terms of it's the only DOAC that was superior to warfarin in reducing the ischemic stroke risk. The experts of Thoracic Doctors Association chest, they're showing that the Bigetran 150 milligrams twice a day is the only pharmaceutical that was superior to warfarin in reducing the ischemic risks. The prevention of stroke, prevention of systemic thromboembolism was reduced. Lower hospitalization risk because of hepatotoxicity at the backdrop of the Bigetran use. This is real-world data. We're interpreting them quite carefully. Especially, there was very limited data for apixaban, not too many patients on that. You see, the Bigetran looks the more favorable option in issues with liver. No issues with parenchyma. I mean, there are no issues that parenchymal damage of liver can play on can affect the Bigetran concentration. This is the algorithm for choosing the pharmaceutical. If the transaminases, if the liver enzyme are higher than 2x the upper threshold of norm, we're supposed to select the Bigetran. The sound from the speaker is breaking up, unfortunately. So we need for the enzymes to go down and not prescribe DOACs until they go down and to keep patients on heparin. The Bigetran will give some nephroprotection to the patients unless we use it for patients with acute kidney dysfunction, which we don't. This was a very interesting publication for me. It's a fresh one, a week or 10 days ago. Co-authors Gregor Lip. Gregor Lip, for me, is the expert whose opinion I trust fully. This is yet another result. Various DOACs in clinical practice. Medicare retrospective analysis was involved. Again, rivaroxaban or the Bigetran, or the Bigetran versus apixaban. Potentially reduced number of hemorrhagic complications. For the Bigetran, I'm also looking at the antagonist. This antagonist is stopping, is getting the hemostasis system very fast to the initial level before the Bigetran was used without hypercoagulation. So once again, the introduction of idarucizumab returns the hemostatic system to the state before the start of the Bigetran administration without hypercoagulation. So Prexbind antagonist could be, its availability in the Bigetran could be the reason to go for it for patients, senior patients with trauma risk, young patients with trauma risk, cholecystic disease. So basically, patients with hernia, with high hemorrhage risk. Well, bleedings, we stop them anyway before therapy. Patients with high stroke risk, thrombolysis can be done quickly, or planned catheter ablation, or some cardiac surgery. Completing my talk, I would like to suggest this. There are no clear-cut mechanisms of personalization of therapy, for DOACs. In my practice, I'm guided by this. If I suspect atrial fibrillation in patients, I will interpret all my doubts in favor of presence of AF. To me, I justify this as the atrial cardiomyopathy theory. Inpatient treatment for severe patients is low molecular weight or unfractioned heparin, which is less frequent. Outpatients with COVID or post-discharge, we get patients back on DOACs. The rules of choice, the rules of choosing are the same as for COVID-free patients. We just need to look at hepatotoxicity, renal function, stability. If the kidneys are unstable, go for the pharmaceutical that is not excreted via kidneys. So high efficiency, high efficacy, safety, minimal hepatotoxicity or none are good points to select this pharmaceutical. Once again, unfortunately, there is no such thing as a perfect DOAC. It simply cannot be one. Thank you, dear colleagues. Thank you for your attention. I'm ready to take your questions. Thank you very much, esteemed Irina. Thank you for the brilliant talk. As always, dear colleagues, who has questions to Irina? Irina, I will ask you a brief question. Indeed, personalization for DOACs, for anticoagulant prevention is very important. There are multiple drugs with multiple efficiency profile, activity profile, although they're all OX. In your clinical practice, for practical doctors, practicing doctors, that short outpatient visit time, it's very difficult to make an informed decision. So now we're talking about digital possibilities, digital technologies coming up. Maybe there could be some applications, some smartphone-based things, algorithm of choice. Maybe that can help doctors play more or less safe in that or another situation. Would that be useful, the use of technology? Valery, I'm deeply convinced that without technology, we will not be able to progress, will not be able to move forward. The experience of our clinic's operation, not just that, other outpatient departments, inpatient departments, colleagues create antithrombotic consultancy centers. They even want to introduce this antithrombotic therapy doctor, antithrombotic, anti-clotting doctor therapy. This therapy is really multidisciplinary. GPs limited time slots for visits. Traumatologists, they don't get to interact with that too much. Sometimes, yeah, traumatologists are more proficient in that than GPs, but still, nonetheless, I believe that one of the clinical departments of our the clinical departments of our chair, we're creating the consultancy center and the decisions making support system in the inpatient department. Unfortunately, we don't have the funds to put together the IT system. So far, it's a 24/7 hotline. There are protocols accepted and implemented that are used as algorithms for action. If there are any questions outside the protocol, so possibly severe bleeding on OAC therapy or thrombocytopenia or some other severe complications, the doctors can call that consultancy center, the hotline, to get advice. If there are any, say, applications, or if there are any ways to incorporate it electronically, we'll key in the patient's data in the dose and you get recommendations, it will be perfect. Yes, indeed. Thank you very much. It's very difficult to make a choice. This personalization is still very, very relevant. Yuri, you seem to have a question. Yes, it's also like, well, music to my ears. I like this topic. I'm always active in that. I was down with COVID myself. I was looking at various medications, or Taxan from the dexamethasone. This was my choice. What if the person is on warfarin? Say there's atrial fibrillation and warfarin, and the COVID infection comes in. We know the thromboembolic risk comes up because of COVID. Do we escalate the dose? For example, the habitual figure was 2, 2, 2.5. Can we bring it up to 3, 3.5 to reduce the COVID-induced thromboembolic complication risk? Yuri, thank you very much for the question. Well, unfortunately, there's simply no data to support any viewpoint. Escalation of warfarin therapy, such need is not described, although there is clinical logic behind it. However, nobody really looked at it. The strategy is this: if the patient is down with COVID, they're switched from warfarin, and we don't get to warfarin if possible. Don't get back to it unless there is rheumatic stenosis or mechanic valve prosthetics. Patients with warfarin, and it's not proven for COVID, there could be some condition for a higher clotting risk for that patient. In that case, I switch to the higher dose range. If the range is 2 to 3, I try to up the dose to get it to 2.5 to 3. Yes, same story in my case. I believe it appropriate. Well, with COVID infection, we simply don't have the data to support it. Yeah, nobody knows. Yeah, this is a super customized, super personalized approach based on common sense. Yeah, managing patients on warfarin without at least weekly on home monitoring, it's impossible. That is true. There is a question. Your microphone is muted, Victoria. You seem to have a question. Yes, now you should be able. Yes. Okay, Irina, thank you very much for the great talk. A question for the post-COVID syndrome. Fulminant myocarditis, myocardial dystrophies. We see that when we're analyzing the deformities. Ventricular rhythm disturbances, torpid extrasystole. What are the time frames for you to extend the therapy, anticoagulation therapy in these patients? Does it affect or does it improve the situation, my myocardial situation? Well, you know, basically, the course of the post-COVID syndrome is easier, is better in patients who are on OX. The COVID syndrome is improving, the post-COVID syndrome. The 30-45 days, I will violate that now if there is no hemorrhagic risk elevated, well, patients without AF. Patients in whom OX are only for that. Well, coronavirus is like venous thrombosis. 90 days is what I advocate. Venous thrombosis and PE, pulmonary embolism, 3 months, okay, 3 months for that syndrome. If, of course, the patient is doing well, the tolerance is well, and there is no elevated hemorrhagic risk. I have not found a publication about the extent of manifestation of post-COVID syndrome. However, there is one publication where the intake of yes, so the anticoagulation outpatiently was not improving the situation, but inpatient department it helped. My opinion is 3 months. 3 months. Thank you. Thank you, dear colleagues. Unfortunately, the time is forcing us to move forward. A small flashback for the 5th webinar of EURA. The link to it is presented below. Yes, indeed, we've devoted 3 webinars for this kind of pathology, various aspects, various issues, surgical approaches to cardiomyopathy, therapeutic approaches were all covered in multiple formats with active international participation. The relevance of these videos is very much high. It's very high. They will not become outdated in the coming years. And something is telling me that something similar to these sessions, well, there are not too many of them, at least in the Russian-speaking space, Russian-speaking internet, the Russian segment of internet. So, dear colleagues, I would like to introduce the next speaker, PhD in medicine, Valeri Ionin, Associate Professor, Department of Physical Therapy, St. Petersburg. It so happens that we share the same alma mater. You also know other significant scientists Moscow-based who graduated from the same. Alexander Myasnikov used to be the resident doctor there. So I would like to welcome Valery here. Several days ago, we met physically in St. Petersburg during yet another session of the All-Russian Arrhythmology Congress. Again, there is a link right here. You'll be able to follow that event that we've been able to cover together during the previous event. It is always a pleasure to see like-minded people whose brain works the same way. Yesterday, Progressive Humanity was celebrating the founding father of the faculty therapy that we know, Almazov. Valery, the floor is yours. Thank you very much, Alex. Thank you very much, Andrey. Indeed, good afternoon. This is a milestone day again for me. I believe that in the future will be communicating space of Arrhythmias Association. So, continue talking of education about the personalized dosage. I would like to cover some accents for possible personalized choices of antiarrhythmic drug therapy in patients with AF. So how come we're still discussing patients with AF? According to the most recent data, the European Society of Cardiology, unfortunately, the prevalence of AF is steadily growing. We also know a lot about the pathogenesis, the risk disturbances, the risk factors that promote AF, and contribute to its progression. The arteriopathy, the atrial arteriopathy comes to bloom, the one we discussed so much. However, the controlling of the risk factors is not always something we can do. AF is slightly more often seen in males. In recent years, younger males, this is indeed a prevalence of AF trend. AF prevalence trend that is not coming with ischemic heart disease. It's mostly obesity, AH, metabolic disorders. And it so happens that 1 in 3 adults 55 plus has potential risk of AF development. So AF is indeed the reason, is the issue that needs to be discussed. Important things about the AF patients. Well, as it was mentioned during the European Congress, these are rhythm disturbances, they don't always come alone. Rhythm disturbances come with concomitant cardiovascular diseases, so cardiac diseases, ischemic heart disease, AH, heart failure. However, we should also keep in mind that it's not always the non-vascular, non-cardiovascular diseases can cause AF to develop, progress, and this will also impact our personalized choices for therapy, antiarrhythmic drugs particularly. obstructive sleep apnea syndrome, obesity, pre-diabetic and diabetes, chronic kidney disease, inflammatory diseases, and so on. Patients with AF are mostly with comorbidities, and this must be taken into account when choosing the antiarrhythmic therapy. According to the European guidelines, when we recorded the AF, we must stratify the patient. The focus is on patients. We need to look at the stroke risk. We need to look at the severity using the modified ERA scale, the burden of AF, how it affects the life quality of a specific patient, the physical activity, routine, and so on. Is atrial fibrillation adversely affecting the patients who is coming to us with complaints of such? However, it is also important to assess the gravity of concomitant diseases, looking at their impact on atrial atriopathy. Left and right atrium. These are the mechanisms that cause the AF to come up and to progress. The strategy of such patients' management is quite straightforward. It's ABC, as Gregory Lipp said, announcing the strategy during the European Congress of Cardiologists. Well, he said that I've simplified your objective, but colleagues, let's be honest here. Oftentimes, a patient with AF is a tough one, is a tough case that requires personalized approach. Anticoagulation prevention is quite actively discussed. Another important point there, the way I see it, is the rhythm control, the sinus rhythm control. How often do we want that? How often do we need that? Indeed, for many years now, in our department, we've been running this scientific direction that is looking at atrial fibrillation particularly. And we're supporting, or we're saying, keeping our eyes open, eyes and ears open. For 5 years, over the past 5 years, we've analyzed the patients that are hospitalized to our therapeutic clinic, and particularly with atrial fibrillation. And we see that more than half of these patients are, well, there is paroxysmal or persistent form of AF. This is the category of patients that is potentially looking at our decisions for antiarrhythmic drug selection. And the symptom burden for these patients, we see them here. Most patients have system class 2A or 2B, modified ERA scale. Mostly they experience paroxysms. This paroxysm might bother these patients, might affect their life quality to a lesser or greater extent. However, pay attention, please. Other hand side, 18% of patients who did not know that they had AF. Coming back to Irina's presentation, I would say that unfortunately COVID is the fact that doesn't only boost the prothrombogenic potential, it also causes AF to spread. Silent ones, silent forms particularly. So please be aware, keep your eyes open, keep your to monitor the situation very closely. Rhythm control strategy. The most recent European guidelines tell us that we are first and foremost proceeding from the symptoms of paroxysms, their impact of the on the life quality, and we clearly understand that non-interventional methods of treatment, interventional, non-interventional, they will not give us 100% guarantee that the patient is forever free of this rhythm disturbance. Medical and surgical therapy are both geared towards the reduction of the frequency of paroxysm, reduction of severity of this paroxysm, make them shorter so that patients will have an easier time surviving them. But still, we are thinking about tomorrow. Upstream therapy, which is often discussed, it is also very relevant. So if the symptoms are there, we need to look at the need of antithrombotic therapy. These symptoms come from the atrial fibrillation. And first of all, we need to assess the facts or the factors that will support or not support the sinus rhythm maintenance. young age, one factor, first and short episode of atrial fibrillation. At the same time, the negative factor is tachycardic cardiomyopathy. In this case, we will definitely go for sinus rhythm maintenance. However, an important fact is this: if there is a prevalence of beneficial factors for sinus rhythm control, we go for the earlier strategy of prescribing of antiarrhythmic or therapy or interventions. Paroxysmal form of AF deserves attention with respect to these tactics, and persistent form as well. In the recent years, many more publications are coming up because of good results with interventional treatment in patients with persistent AF. Patients, especially down with heart failure with reduced ejection fraction. The patient choice, this is the wording that we get in this ESC 2020 guidelines. This is not to say that the patients can select to take or to not to take the drugs. No, it's about joint decision of the cardiologist, arrhythmologist, electrophysiologist, and the patient, if there is a multidisciplinary possibility. And we also look at the desire of the patients, medical or interventional therapy. Why we're talking about early strategy, sinus rhythm control? The East FNet results that were presented during the most recent European Congress, they tell us the earlier we go for the sinus rhythm control tactics, medically or surgically, we clearly get to a lower mortality and to lower strokes, lower risk of stroke development. This is a very important fact that we need to remember. The patients must live on and they must lead a higher quality life. And in this respect, we know that the goals of antiarrhythmic therapy, both surgical and interventional, they deserve the attention. The objective, according to the European guidelines, is reducing the burden, improving life quality, bottom line, for these patients. This is indeed the case. This is what we're guided by. The efficiency, the efficacy of antiarrhythmic pharmacotherapy in maintaining sinus rhythm is moderate. We should not strive for some stronger drugs or more powerful drugs, more potent drugs, unless there is a need for them. On the other hand, if there is one antiarrhythmic drug which is not efficient, well, its clinically acceptable response can be obtained using other pharmaceuticals. For example, if we prescribe an antiarrhythmic, we're supposed to assess its efficacy. It's not just subjective, not just complaints, but also repeated 24-hour monitoring for these patients. However, if the paroxysms, if the AF is maintained and they bother the patient, they affect the life quality. So let us consider other options of prescribing antiarrhythmic therapy. So the algorithm of sinus rhythm long-term control, if we've come up with indications which patients require control, and definitely the diagnostics and management, the upstream therapy, so-called upstream therapy, all of this is geared towards primarily to impede the progression of atriopathy. The fibrosis, atrial remodeling, this must be stopped. And this is a very important strategy because it is this strategy that will help this patient live longer without atrial fibrillation, AF-free. However, if we still need the surgery, if this is a patient with minimal structural damage of the heart, if there is no history of MI, if there is no HF with reduced ejection fraction, if there is no dilational CMP or other forms of CMP. So in this scenario, the selection of treatments is diverse for medical therapy. Particularly, catheter ablation is also indicated, is also used in this category of patients. However, out of all antiarrhythmics available in Russia, we know the ones recommended by ESCs, propafenone and sotalol. If patients present with not just symptoms, but also with some verified structural damage in myocardium, or a history of MI or scarring or heart failure, severe valvular pathology, in this case or in this scenario, we play safe. 1C class is less recommended antiarrhythmically. Amiodarone or sotalol, less recommended. So looking at ways to personalize treatments, we know that patients with refractory paroxysms and the symptom classes 2B, we will start with sotalol. However, if sotalol is inefficient, we will consider switch to amiodarone. Amiodarone is the antiarrhythmic, the only one recommended for patients with AF and reduced EF. This is what we're supposed to use in this clinical setting, in this clinical scenario. The most recent guidelines are looking a lot at antiarrhythmic therapy. Safety should not be disregarded. Amiodarone is not first line because of that. If we're talking about patients without structural damage to the myocardium, sotalol, we always monitor the QT interval, potassium in blood serum, creatinine clearance, and we definitely keep in mind that the 1C class is also quite actively used in Russia. In Russia, we have broader possibilities because there are more drugs registered of that class in Russia. So what do Russian protocols, Russian guidelines approved by the Ministry of Healthcare last year say? Indeed, class 1 and class 3 of antiarrhythmics are used for patients without structural heart damage. It's most often category of patients that come, patients with fibrillation. It's possible to initiate beta adrenal blockers therapy. Patients with psychological, psycho-emotional factor strain, if it provokes AF, the beta adrenal blockers will get the good result. However, amiodarone without structural heart disease, we're only considering that if it's impossible, or the beta blockers, the 1C class and sotalol are inefficient. Only then we're looking at amiodarone. Talking about class 1C antiarrhythmics, the absolute contraindications to consider these are basically this. It's patients with reduced ejection fraction in heart failure, LVEF less than 40, acute ischemic heart disease, or basically ischemic damage that requires revascularization, and pronounced LV hypertrophy with wall thickness over 14 millimeters. Arterial hypertension, heart disorders are not contraindications to prescribe 1C class pharmaceuticals. I will allow myself the luxury of showing you a brief clinical case that requires the application of personalized medicine. It's a woman that came in September last year, frequent paroxysm complaints that are happening virtually daily at the time of admission. Of course, it causes quite serious psycho-emotional anxiety. We always pay attention to that. We also highlight this, that this kind of paroxysms are registered late at night or early in the morning, which is very tough for the patient. Psychologically, it's affecting her life quality. She's gone a long way from first verification in 2014. There were attempts to prescribe beta blockers that did not give the stability of the rhythm. The AF paroxysm even got worse. Sotalol, there were attempts to do that. Sotalol was prescribed. She was taking it at the time of admission. So basically, the resources of antiarrhythmic choices have been exhausted, but the paroxysms are still quite often. And she was hospitalized to look into surgical ways of treatment. We analyzed the situation in echocardio workup. We saw no pronounced hypertrophy of LV, although it was really there. There was no dilation of chambers. There was intact ejection fraction. Patients with risk factors, obesity, diabetes mellitus, low density LDL cholesterol, and fasting glucose. We looked at all of the findings. We even do the coronary angiography to exclude heart pathologies. However, there is no substrate of ischemic heart disease. There's no IHD. In such patients, we do nighttime paroxysms require us to exclude the obstructive sleep apnea syndrome. In this case, there was a mild apnea. Weight correction must be done. However, there are no indications for respiratory support. In nighttime, the paroxysms, fibrillations, atrial fibrillations are recorded. So what is the precipitating mechanism? What is the underpinning mechanism of this AF? Maybe when we find it, it will give us a new light, it will shed a new light on the drug therapy. AF is multi-component. Structural changes, fibrosis, remodeling of the atria is a substrate. But the triggers that cause us to personalize the choice is autonomous vegetation system. Hyperactivation of sympathetic system and parasympathetic system, hyperactivated. In this clinical case, we're looking at specifically this, vagus-dependent or Brady-dependent form of AF. It is often seen, more often seen in males, a younger age, without pronounced myocardial damage. However, too much food at night, too much beer at night, alcohol, it causes that those paroxysms at night. Beta adrenal blockers, even propafenone prescribed for nighttime, it also has beta adrenal blocking effect. They are boosting this Brady-dependent AF development cause of development. This is a Brady-dependent patient, nighttime paroxysms. At the same time, we realize there are ways to remedy that. If that's adrenergic, psychological stress, too much physical stress, arrhythmias are triggered by that, beta adrenal blockers, propafenone, will be more efficient. However, what do we do about Brady-dependent patients? There are ways, or there are options. In Russian 1C, pharmaceuticals are registered. There are experimental works that show, against the backdrop of stimulation of the vagus, etesizine retains its electrophysiological effects and partially eliminates the bradycardia caused by stimulation of the vagus. It also prevents the acceleration of conduction through the atria. It has a clear cholinelytic effect, and it affects the parasympathetic nervous system. This is the pharmaceutical that will not affect the heart rate. Prescribing it for nighttime for patients with Brady-dependent AF forms, it will not make them worse. It will not increase the frequency of paroxysms of AF. So our patient does not have contraindications for this. 1C class can be indicated. There are no findings, adverse findings on EKG, on echo KG, and there are no structural heart diseases. So we decided to go for etesizine, 1 pill 3 times daily. Of course, we need to monitor the EKG. We're monitoring the situation, an electrocardiogram. But at the same time, before the next contact, several months on, we have not seen a single case of AF paroxysm. She even failed to believe that it was even possible, having been subjected to the tough choices previously, tough choices of antiarrhythmic therapy. Etesizine is acting towards this vagus form of AF. It will give us a better control of sinus rhythm. There are works to confirm that, confirming the action of this medication, lower paroxysm, lower duration, lower frequency. This is exactly what we need to reduce the burden. So as a conclusion, dear colleagues, the focus of contemporary guidelines is the patient with atrial fibrillation and concomitant associated conditions, the correction of which plays an important role in the management of arrhythmia. The choice of a rhythm control strategy is determined not only by the patient's desire and clinical indications, but also the pathogenetic mechanisms that we find as underpinning the onset and progression of atrial fibrillation. Patients with an indication of more frequent paroxysm of arrhythmias at night, signs of bradystoly, as well as risk factors such as obesity, food and alcohol consumption before the sleep, OSAS, sleep apnea, all that most often these patients have a vagus-dependent variant of atrial fibrillation, require personalized therapy. Thank you very much indeed for your attention. Should there be any questions, I will be pleased to discuss them right now. Thank you very much, esteemed Valery. Thank you very much for the talk, dear colleagues. Yes, as a co-host, as a partner, may I abuse this opportunity? Yes, of course. Great talk, amazing. All the new things have been reflected. I have this question. So possibly over the past 38 years, I've looked at all those drugs. I've been using all of them for my patients. Not a single one emerged in the past decade. Etesizine is what, 30 years old? Cardiomyopathy, amiodarone is very old. So how come there is no progress in developing good, reliable antiarrhythmics to treat AF well with minimal number of side effects? Maybe this is the holy grail that's not there by definition. Yes, indeed. This is the kind of objective we would all see resolved, a universal antiarrhythmic. But I believe that no, there is no such thing as this holy grail, because the atrial fibrillation itself, why it's attracting so much attention, it's so multifaceted. There are many various precipitating mechanisms, triggering factors are different. Unfortunately, this all leads us to conclude there is no such thing as a one-fits-all approach. In this case, we need the comprehensive approach. Risk factor modification, pro-arrhythmogenic and trigger factors elimination. Until now, until present, I believe that we have been deprived of the possibility to find that versatile medication that would save all the patient from repeated paroxysms, because the AF is diverse as a condition, and the clinical practice is just confirming that. So what am I getting at here? Basically, maybe we should make fewer attempts in testing various groups of pharmaceuticals. The European guidelines telling us class 1 or class 3, try it once, and then it can be well, that patient, if they don't respond to that, heart rate control or say ablation. So we shouldn't torture the patients with multiple therapy changes, or we should go for RFA, destruct the node and put in the when the day is gonna come. After how many trials of pharmaceuticals will it take to get us electrophysiologists on board? Well, I will agree with you, because this selection of antiarrhythmics in a single patient is causing those patients to lose the proper life quality even further. That patient that I was referring to, it was that example. She presented, she was admitted to us. We were looking at interventional treatment. And we saw that previous doctors were trying to select multiple antiarrhythmics and they failed. We consulted with our arrhythmologist, with our electrophysiologist. In this case, we got the consult. Good atezazine therapy still did not preclude that patient to demand RFA for herself. And we did RFA for that patient 4 months after the ablation. We saw the improvement. Yet another antiarrhythmic was added to wait for that 4 months after presentation, after initial presentation. No manifested dilation of the left atrium. So the clinical predictors are there. So we wanted to improve her life quality before the surgery that we would have done anyway, as per the patient's request. Why we went for atezazine? Well, we were simply looking at options. So that's 3 months post-ablation. What kind of drug would be most efficient? And we looked at atezazine. PV isolation was done. She was receiving atezazine 3 months after the surgery. So I can make a conclusion. There was a multi-day EKG monitoring recently, not a single paroxysm. And clinically, she felt none either. So I believe that in the future, we will try to modify lifestyle, weight control, blood pressure. Maybe in that case, antiarrhythmic therapy will not be required. I fully share your viewpoint. The necessity of antiarrhythmics, of interventional methods, it's not replacing. Yes, so we are on the same team. It's not replacing; it's mutually augmenting. Thank you very much, dear Valeri. Thank you very much for the Q&A session, dear colleagues. We need to move forward. Please, a small flashback. 6th webinar of Eurasian Arrhythmology Association. Okay, to continue the topic of the flashback, the first time our good friend, our colleague, certified expert in Europe, in applying methods of continuous electric stimulation, implanted devices, Dmitry Volkov, medical doctor. He is head of the department of ultrasound diagnostics methods, minimally invasive treatment methods, Institute of General and Urgent Surgery, named after Zaitsev, National Medical Academy of Sciences of Ukraine, Kharkov. Dmitry, we are so glad to have you. The topic of your presentation is modern approaches to achieving physiological cardiac electrostimulation. Thank you very much, Andrey, for the invitation. Dear colleagues, good afternoon, everyone. I would like to continue my presentation that my colleague, Yuri Karpenko, my mentor, my teacher, started. We're working together on this topic, not just us in Ukraine. I would like to start from the basics. Physiological electric stimulation is construed differently by various experts, but what Yuri has said, most likely the Holy Grail has not been, well, it's not there. The God and evolution have created this the best way possible. Stimulation of the heart's own conduction system. Well, the obvious ideal still needs to be found. If it's a person with multiple physiological damages, lesions, multi-tier conduction blocks, psychiatrical changes, scarring in the myocardium, there is a certain dissonance between electric and mechanical synchronicity. He's looking more at the mechanic side, although I agree with him, but electric parameters are easier to go by as indicators, as ways to assess treatment outcomes. Possibly there will be a novel method coming up that will look at the energy of myocardium with various stimulation methods. The blood flow, the turbulence, I hope that these technologies will emerge in the near future. The foundation was laid back in '58 when the first ICD was implanted. The first stimulation of right ventricle was done. Mid-70s AV synchronization. This helped beat the atrioventricular asynchronicity. It was a good step forward. Early 90s frequency adaptation. Yuri came to Kiev to a congress that we also visited. It's a great person. We talked for a while. There was a big step forward. The continuous electrostimulation, his bundle, left bundle block, left bundle branch pacing. The colleague Vyacheslavovna that was mentioned several times by Yuri, he improved this procedure using better devices. One in 2018, quite recently, improved this even further. He did the LBB pacing. Basically, we discussed this with Yuri. This method of therapy, epicardial therapy, it's basically helped us move forward with electrical physiostimulation. But there are some aspects that we need to consider. So what are the areas and what are the possibilities? What can we stimulate? As his bundle, the left bundle branch. So there are 6 areas. We can stimulate any one of them. However, if we're talking about the stimulation from a single point in the ventricle, a single spot, maybe it should be it should be multiple areas, 1 through 4, to spread to both ventricles. So that's the his bundle, that's the left bundle branch, that's the left and right side of the ventricular septum. Each one of them deserves the right to live. I would not put this to rest, not just the thinner part, mapping of the right ventricle to detect thinner QRS or narrower QRS complex. It gives us better results. Although the patients had a certain extent of asynchrony when we were stimulating the septal part of the right ventricle. So again, if we can get this complex, we don't have to bother any further. 15, 20, 30% of patients at best can receive this complex. In other patients, this complex will be wider, which is an issue. following this principle, you see, our approach was here. It is more anatomical. We're trying to get the electrodes through the narrowest part. In this patient, the electrode went through the lower part of the septum and it went into the septal papillary muscle. So this gets us perfect synchronicity, and the electricity is not. Mechanically, it's simultaneous. The synchronicity electrically is not. Unipolar stimulation. You can see that we're only touching on the left part, the full blockade of the bundle. Higher amplitude gives us a higher amplitude. I mean, the QRS gets expanded. This is incomplete. This is complete blockade of the left bundle. We didn't introduce the lead too deeply, but well, we got very good results nonetheless. This is what it looks like. Marek Ardashev came to Ukraine as well. He did some surgeries. It's one of the advocates of this method in Europe. He published an article for technical reasons why it works or why it fails. Particularly, he identified 3 types of electrode penetration, or 3 types of screwing in the electrode in the transseptal approach. 2 of them are bad, not nice. The entanglement. Entanglement is when you're trying to push the electrode forward, but it's not going forward. It stays in the same spot, and it cannot penetrate even the very first level. I mean, this endocardial entanglement effect is the toughest bit. You need to get through the endocardium. It's quite elastic, but it's quite dense at the same time. So we need to position the electrode correctly, and that step will be passed. The drill effect, second effect, the so-called drill effect, when we're just screwing in the electrode in the myocardium and it's not moving forward properly, the electrode, you're basically drilling out the pieces. In the second image, you see how this electrode removed the normal myocardium. This is not the best way to do it. And the third is a screwdriver effect. It's when, well, it's pretty self-explanatory. Several turns, 3-4 turns, the lead can penetrate quite deeply. Not just several millimeters, it could be a single centimeter or even deeper. Might seem untrue, but this is the case. This can happen. This is all about how you start this movement and how you carry on. Now I'd like to show some X-ray imagery, how it looks like. This is the entanglement. Now it's playing back. If you're seeing this kind of effect, you don't have to go on the left, because the electrode will never go forward. Stop. Stop. Retract. Free the tip from the tissue that will most likely be there, and continue in a slightly different zone, a slightly different angle. The second picture is the drill. You see the contrast medium, it doesn't just go along the septum, it goes through. And also there is a small vein that is contrasted, that we nicked that vein with the electrode. It looks like a major damage. There are cases of coronary artery damage if it's the septal branch is located quite high. In this second case, the patient was doing well, but we had to reposition the electrode because there was a big risk of dislocation. There is a big hole, and well, put crudely, the lead can fall out. The third case, it was not perfect either. We wanted to get it deeper. Well, we'll consider it later on. This is the screwdriver. Several turns of the electrode help us implant it the right way. This is another example of the same. This is the lower part of the septum. The start of the movements when we just drilled. So we're turning, not drilling. And several movements, you see it's going in quite deeply. The bulk of the electrode is within the septum after just several turns. You see where it depends on here. The thickness of density, it's mostly density. What Yuri has shown, the results of 15 millimeters, the electron passed that like knife through butter. But you see the white septum on the echo. We always assess it pre-op to realize where the thinnest and the thickest areas are. And we try to intraoperatively to follow the zones which are more favorable for lead implantation. So quite dense, but not too thick, that medial zone. The electrode is going quite nicely. The myocardium is not very dense, and there are left hand and right hand side of narrow, thin tissue. So we acted very carefully not to perforate the septum or the ventricle, because in that case you can, if you're too active, if you're too radical, you can perforate the left ventricle. Okay, mapping and selective stimulation of his bundle. HV, QRS, perfect complex. However, the voltage was around 3, and since that patient required atrial nodes, AV nodes, ablation, I didn't go for that high voltage. Myocardial involvement, we went for a lower voltage. So this is possibly the main problem of his bundle stimulation. You need to find it, you need to enter it, and you need to stay there. It's a very small area. It's like finding a needle in a haystack. The movement itself helps shift the electrode just a bit, just a tiny bit. There was a 1 volt current, although it became 7 volts, just say 7 days on, and the electrode did not move. A resurgery 1 year on. There were 2 electrodes next to each other. It was possibly 1 or 2 millimeters. It was a radical change in the situation. It was that damage when we were screwing in the electrode. Perfect methodology, but it's very difficult to reproduce. This is its main limitation. However, well, we've done that for multiple patients. Echo guidance. You see the blocked electrode in the his bundle zone septally. We're using his optimized therapy for a patient with defibrillator. It is very difficult to get in. It is very difficult to position the electrode. And you need to understand that you have broader opportunities there. Don't just stay stuck with in a dead end. The his bundle is quite big. No matter where you land, you'll get a good result. Left ventricle, we often disconnected, like a fusion effect of the innate conductivity. You can see the blockade, the his bundle blockade, left bundle branch blockade. I mean, a QRS is quite short. The distances are quite short. The complete, almost complete left bundle branch blockade. Yuri has shown the pictures of around 100 milliseconds. The perfect CRT, even the perfect cases, will not give you a QRS, so that's short. Okay, moving forward, there is traditional CRT, perfect method, works fine. We continue working with it. We did not discard it. I will show you, give or take, the balance between these methods. Also a great result for many patients. However, there are limitations. First of all, it's not physiological. This is not supposed to be this way. A healthy heart is free of that. So in this case, we are combating, we are going against the physiology. There are some technical limitations as well. If you're trying to do the right thing anatomically, you will end up in a lengthy surgery. There was one case of coronary sinus high placement. So many tries, it took many tries to isolate that vein, to get the lead in there. We finally succeeded, but it took a lot of efforts, a lot of time. So that electrode that we've implanted in the left septum side, it took us 5 minutes to get it there. It took 90 minutes for the left and 5 minutes for the right electrode, 90 versus 5. Well, things happen. However, technically, it's more appropriate for more patients to go for the latter option. QRS, EKG, not the perfect result, but nonetheless, when the left septal stimulation and the epicardium of the LV combining, we got it perfect. This is the case I wish to showcase in more details. Full blockade of the right bundle branch. We know that in severe heart failure, this is worse than left bundle branch blockade. Patients with RBBB are not optimal for CRT. We also know that. So I believe that these patients clearly need either isolated stimulation of the His conduction system or combined stimulation, the His optimized CRT. In this particular patient, this was a patient with a systolic form of fibrillation, a tough one with apnea. We wanted to do the AV node ablation. We wanted to go for the ablation. If we want to do that, we need to stimulate the heart. If the EF is just 40, 42, and we could have been looking at CRV, but we went for CRT. We decided in favor of the hot CRT, the so-called hot CRT. We've mapped the His bundle. We've put in 3 electrodes. His bundle, right ventricle, left ventricle. The right ventricle, just in case if things happen to the His bundle, we wanted to switch to the RV stimulation. This is the His electrode involving the conduction system, right ventricle with engagement and with loss of engagement. You see several stimulation complexes with various morphologies. It's always very interesting. So these are the EKG patterns that we could have been looking at. Stimulation, the blockade. So we see that there are, well, pictures are this. The patterns are self-explanatory. Hot CRT is improving. It's a narrow QRS. AV node RFA, it didn't work on the right. We had to do on the left. The right was completely blocked, RBBB. This is the final option of this result of 122. Good mechanical synchronization, working well on the right-hand side. So this is a great method, particularly for these patients with significant RBBB. However, there was most likely an LBBB in this patient as well. It was less pronounced. So we have 2 more methods to cover. One of them is so it was His optimized hot CRT. Now we'll be talking about left bundle branch, LOT CRT. This is what it looks like. This is what we can do. No imagery here. I'll just show you the EKG of a very tough patient, severe patient with 16 or 18 ejection fraction, minimal. It's untypical LBBB, although it's there. And the PQ interval elongated, the blockade. This used to be the perfect, used to be suggested as the perfect patient for His bundle stimulation. But in this case, we considered the combined option, the LOT CRT. Shortened QRS down to 132, checking the thresholds, the amplitude, lower, most likely myocardium was involved. When we're finally connecting the stimulation, epicardial stimulation, we get the best possible complex, QRS 110 milliseconds. So this is how LOT CRT works combined with the conventional one. What else does it give us? Well, there's always backup. You can always use the backup if the initial or if the primary device fails. Even if one method failed, the other one, well, there's a whole bunch of other ones that are bound to work. So in any situation, you'll be right. And the CSP conduction system stimulation plus right ventricle. I've shown that for left bundle stimulation, we can block the right bundle branch. It's not significant in most cases, but in some it might. Stimulation of the right ventricle in this case helps us reduce or overcome subventricular stimulation. We've used this method in patients with defibrillators, or in whom defibrillators were indicated. We've used defibrillators, chambers, so bicameral two-chamber defibrillation, the bichamber ICD, but one of the channels was used for stimulation. There are issues of programming. This is a person with complete block, Frederick syndrome, ICD, absolute indications, EF quite good, 48. There are no clear CRT indications, although the patient was comorbid, so well, it's best to go for it at once, because stimulation will not be, well, so there will be some kind of resynchronization necessary. Very bad complex, 48 going 38, it would have become 38 ejection fraction in 1 year on. So we were looking at options of physiological stimulation. We went for the left bundle branch stimulation. This is how QRS changed. It was a radical change. Left hand side, full blockade, full RBBB, right bundle branch blockade. And this is the perfect complex 10105. And this is the involvement of the right septal part that I've been talking about. We lost it, we got rid of it just by reducing the amplitude. This is the limitation of the defibrillator. There are small scissors here. If unipolar, you wouldn't have done that with unipolar. However, you can lose this anodal engagement. If you're concerned about the patient's with full block, you have a backup option, right ventricular electrode. You can put it in addition, even if you don't contact, if you don't capture it, you will still have a backup. This is our experience, 22 cases. We mostly go for the left septal part or left bundle branch stimulation. We used both, hot lot and CRT were quite actively used. Although we will need to look at the right ways or appropriate ways, whether we should be guided by QRS. Maybe Yuri will elaborate on that. If we see good resynchronization, no need to go to radical. You see, there have been 5 failures. Resynchronization was done with standard implantation. So in one patient, one failed case, we successfully implanted the HIS electrode. The indications, class 2A in America, where this whole thing started, where there is quite significant progress. ESC, ERA, EHRA, class 2B. I haven't read them, but during the session, it was announced that it's class 2B. Also, if there are no large trials, large randomized trials, they're most likely they're coming up, but in our practice we see a huge potential of this method and we're trying to use it. And once again, our approach is, the green is quite contemporary. The yellow are good indications. The green ones are modern, and the yellow ones are good indications the way we see it. We believe that patients with narrow QRS, we use the septal stimulation of the left ventricle. Septal stimulation of the right ventricle. If there are distal disturbances of AV conduction and ejection fraction of 40 to 50, CRT or septal stimulation of the left ventricle. If there is left bundle branch blockade or traditional CRT therapy indications, CRT or LBB stimulation or His bundle stimulation. For the right bundle branch blockade for RBBB, we should go for SPS and hot CRT. Untypical intraventricular conduction blockades, especially in AVB, could be LOT CRT or CRT. In continuous and persistent form of AF, the atrial channel should be used as an additional one for SPS, trifocal stimulation. It would be nice to have the atrial channel as independent. We could have programmed it to become ventricular. In that case, it will broaden our arsenal for the most significant patients. Okay, this is my completing slide. So, involvement of the right ventricle, His bundle, unipolar, we're overcoming the blockade. So getting this diversity of QRS complexes from one case, well, it's really amazing. Thank you very much. Have a good day, everyone.
Спасибо большое за такую элегантную лекцию, достаточно сложный материал.
Dmitry, thank you very much for the elegant talk. This is indeed tough material. All of us here are cardiologists. In 2 or 3 sentences, as cardiologists, how can you summarize for the cardiologists, for our colleagues? So, electrophysiological stimulation. What kind of methods of echo, EKG, or echo KG control would you recommend it for the cardiologists? Because electrophysiology is our kettle of fish. What about the practicing doctors? What should they know about this septal stimulation? Thank you for the question, Yuri. Well, I'll tell you once again, right away. My lecture was supposed to be more applied, or to have more applied nature for the electrophysiologists who are trying to start this methodology. Unlike our experienced, mine and Yuri's combined, it was very difficult to start. It's very important to have a mentor. When I went to Yuri, when I looked at how he does it, I was able to complete several surgeries. Initially, it was an uphill climb, really, for me. For the referring doctors that refer to us, for cardiologists, well, the first thing I would highlight, people should be aware of this method. I know that some cardiologists are afraid of stimulators. Normally, routinely, this method requires EKG control. Follow-ups of pacemakers, we don't use EKG too often in routine practice. We're guided by the electrograms from the programmator. In selective involvement or non-selective involvement engagement, if you have an EKG, it is much better to have one. There will not be a single threshold, there will be multiple thresholds. Conduction system, engagement of myocardium, this all must be reflected. We care about the dynamics, we care about understanding what we engage. Like I said, bipolar can be switched to unipolar and it will get you a different result, completely different result. This is the upside and this is the danger of the method. So I believe that the cardiologists are supposed to first be aware of this, that this method exists. Secondly, when doing follow-up with these patients, you will do that. Well, you might not be able to say anything. So basically, you will. Thirdly, the best candidates in my practice, you should start with proximal blockades with. Well, this method is not critical there. I mean, these patients are more favorable in terms of training. In our cohort, it was not the case. We had the toughest patients. We could not do CRT for a number of reasons. There was a lack of device, or say the traditional CRT could have triggered defects. So RBBB and untypical LBBB, these are the indications. All patients with AV blockade of grade 1. These are the patients in whom conventional methods do not give 100% results. These are the candidates for the Brady system stimulation, isolated or in combination with multiple methods. Possibly the combination will give us an even better result. So essentially, this can be done. Tri-chamber devices might come to market, might emerge, or might develop. Thank you very much, Dmitry. I see you at workplace. So if you can, please stay on until the end. I will request a flashback of webinars 8 and 9, and then we will give the floor to Viktor for his talk. Technical people. We wish Professor Ardashev a good flight and a soft landing, soft touchdown. We will look forward to further webinars with his participation. Our current president of the Eurasian EURA Association, Viktor Snezhitsky, fellow at the National Academy of Sciences of Belarus. He will talk about, Professor Snezhitsky will talk about the tried and true, time-proven and new criteria for stratifying the risk of sudden cardiac death in patients with heart failure. Good afternoon, dear colleagues. I would like to highlight points of stratification of sudden cardiac death, SCD, risk factors, life-threatening arrhythmias in patients with chronic heart failure. The HF patients is possibly the most vulnerable category out of all of them. If we're talking about the groups of diseases that are etiological factors, factors of elevated risk, with a structural heart disease, patients with issues of heart conductivity, ejection fraction under 35%, patients with some kind of genetic predisposition, including canalopathy, Possibly the cause of death could be something else, electrolytic disturbances, stresses, a whole number of factors that can also cause fatal arrhythmias or issues, no meaningful structural pathologies. Life-threatening arrhythmias, ventricular rhythm disturbances, although in some cases at the backdrop of supraventricular arrhythmias or Wolff-Parkinson-White, WPW syndrome. This could be life-threatening. It's for tachyarrhythmias. For bradyarrhythmias, it could be life-threatening situations, not just systole, tachybradycardia, could be various AV blockades of second or third grade of distal type, binodal disease, as well as atrial fibrillation with cardiac arrest and clinical death. Considering this issue from the viewpoint of arrhythmia leading to sudden cardiac death, and arrhythmias causing SCD, we know that around 60% in that paradigm is ventricular tachycardia or ventricular fibrillation. VF alone is 8%, polymorphic to TDP around 13%, taux de pointe around 13%. Ventricular paroxysmal tachycardia is mostly patients with IHD, MI, history of MI, the chronic aneurysm of left ventricle. Also post-inflammation issues, post-inflammation cardiomyopathies. Hypertrophic cardiomyopathy, HCMP, is the most frequently seen in ventricular paroxysmal tachycardia. And then there is a downward frequency canalopathies and idiopathic ventricular tachycardia. High-risk criteria are patients with early episodes of ventricular tachycardia. So it's previous cardiac arrest, paroxysms of sustained VT, paroxysms of polymorphic VT, ventricular fibrillation, and systolic dysfunction. Patients with lower ejection fraction, under 35, they are in the risk group, but somewhat lower. Patients of higher risk is patients with a history of MI, proximal stenoses of coronary arteries, particularly left main, the sudden cardiac death is true for patients of cardiogenic syncope, valvular stenosis, particularly manifested ones, aortic stenosis, aortic valve stenosis, and patients with a history of SCD in close relatives. Of course, there are other risk factors of SCD, but these are the most frequent ones. It is very important for us to have a clear picture of the heart condition, structural heart damage, yes or no, in a specific patient. And first and foremost, given the current guidelines, we're looking at the presence of the cardiac pathology, whether it's there or not, and the reduced ejection fraction. If the ejection fraction is under 35%, we will categorize, we will stratify this patient into a high-risk group. And oftentimes, these patients will have the perfect indicators: primary and secondary prevention. If there were events, if there have been events, it's secondary prevention then. At the same time, there are issues, or that there are questions then still. If we're looking at a 1 year or 3 year event in patients that have the ICD, only 1 to 5 of patients with CVD or cardioverter defibrillator implanted will require therapy after 1 year. The vast majority of patients with a CVD will not require therapy, or will not receive therapy after 3 years post-implantation. It is also important to note that over 70% of all cases of SCD in the general population occur in the individuals with a high ejection fraction, over 35. So quite a high proportion of patients, quite a big proportion of patients is not eligible for an ICD implantation. To those whose ejection fraction is higher than 35, this is a strict criterion. Given these facts, I would like to bring your attention to the consensus document, Expert Consensus on Risk Assessment in Cardiac Arrhythmias. The document has been prepared, follow-up of patients using the appropriate methods of diagnostics, trying to gear the treatment to a particular population, a subpopulation, and to assess these risks, particularly life-threatening ventricular arrhythmias and SCDs as an outcome. This is the data, 3 classes of recommendation in green. Green is where it's necessary and where it should be done, and the yellow is dubious, when this study should be done, and not, and red is when it's not to be done. EKG is necessary in the majority of patients with a known or presumed heart condition. When we prescribe, when we suspect some kind of canalopathy, LQTS, Brugada syndrome, ACMP, EKG is also indicated. EKG during exercise provides diagnostic and prognostic information for syndromes such as LQTS, Brugada syndrome, ACMP. Ambulatory EKG allows documenting unstable ventricular tachycardia and assessing the prognosis in patients with ICMP, HCMP, or ACMP. Also, some types of higher risks can benefit from an EKG. So this is a second grade recommendation class, yellow heart. These patients can be identified using other methods. When EKG is used with TWA, TRS, VRS, basically this gives a better risk stratification. Unfavorable events for ventricular ectopia, extrasystole over 10,000 within 24 hours, or more than 10% within a longer time period. In this case, the recommendation class is the highest. A lower class, but this criterion can also be used, is when the cardiac function assessment and screening for systems of heart failure may be considered in patients with frequent polymorphing PVCs, or PVCs with QRS the duration over 150 milliseconds, or PVCs with adhesion intervals under 450 milliseconds. Visualization methods, echo KG is important, the highest grade of recommendations, to look at particular structural heart damage and to assess the ejection fraction. MRI, cardiac MRI, is useful in determining the etiology of ventricular tachycardia and identifying any scarring, any psychiatrical or inflammatory changes in the myocardium, the hemodynamic disturbances. Most importantly, the tissues, like I said, the scarring or any fibrotic lesions can be found on MRI, or the inflammatory or post-inflammatory changes in the myocardium can also be detected by MRI. PET of the heart can be performed. In some cases, this is second grade recommendation to try to detect inflammatory or scarring in the myocardium and identifying cardiac condition. Invasive electrophysiological workup of the heart. In this consensus report, the highest class for patients with a history of MI and with syncope, and in whom the data of the previous survey did not find any link between the syncope and VT. At the same time, the syncope is suspected to be the cause of VT. Lower grade recommendation, IEPS can be performed in patients with ICM under 40% ejection fraction. So basically, it's idiopathic cardiomyopathy, ICMP, and EF under 40% with unstable VT. No indication for ICD. The must criteria. IEPS can be considered for patients with syncope and bifascicular block with the mechanism of syncope after non-invasive examination, when the mechanism of syncope after non-invasive examination is not established. IEPS can be considered for SCD, so that these are the contraindications when the QRS. So IEPS can be considered in patients with syncope or bifascicular block when the mechanism of syncope is higher. The contraindication is basically LV dysfunction, unstable VT, QRS direction over 880 milliseconds. ILR, event monitor, loop recorder, is indicated for patients with syncope and high risk criteria who have known cause of syncope, who do not have a genetically or generally accepted indication for CVD or pacemaker implantation. ILR may be considered second grade in patients with palpitations, dizziness, lightheadedness, frequent ES, unstable VT, as well as in patients with suspected AF or after AF ablation. So we should get back to the guidelines for diagnosis and management of syncope. We're looking at the risk of this syncope based on the criteria that are outlined in these guidelines, particularly ESC 2018. I will not dwell on them too much. Most likely we'll full well aware of them. Also, it is very important to assess the other side that might be useful for risk assessment for sudden cardiac death. It's a number of biomarkers that might be useful. Inflammatory, fibrosis biomarkers, as well as genetic markers. Either polymorphic options of some genes or certain mutations. Genetic workup is grade 1. MRI with late enhancement to detect fibrosis or scarring can be useful when assessing arrhythmic events in patients with AF and patients with cardiomyopathy. A number of meta-analyses and RCTs has shown the benefit of MRI to improve the outcomes and to prognose the efficacy of various types of therapy. Biomarkers, this plasma NT-proBNP can be used to differentiate patients with higher or lower burden of AF. That document is revolving around other markers, particularly ST2 and XM3. Matrix metalloproteinases, MMP9, were used to assess the prognosis. But so far, the information about these has not been reflected in the guidelines. Only the plasma NT-proBNP has gathered enough data. For C-reactive protein, there's quite sufficient data to recommend plasma CRP to predict the risk of AF or atrial fibrosis development. AI and machine learning, this topic is broadly discussed these days because the data has been obtained according to which we can monitor the efficacy of AI use for both AF analysis and assessing the likelihood of systolic dysfunction in the LV detection, high sensitivity and specificity and accuracy in risk stratification in patients with IHD, high accuracy in prognosing their mortality. Mayo Clinic has developed quite a lot. A similar trial was done in Belgium for a different category of patients that were on psychotropic drugs. Also, Assis-Dale scale was used based on AI to look at polymorphic TDS or the TDP tachycardia. It's also based on the attending physician gets the information about the extension of QRS intervals, and they can use or they can take measures. For example, they can adjust the machine or they can adjust the drug therapy, sorry, if it's multi-drug therapy that can expand or that can contribute to narrowing the QRS and prevent the ventricular tachycardia. A similar model has been created in Seattle to look at the use of ICD implantation benefit in patients with chronic heart failure and ventricular arrhythmias. It's a multi-factor model. Most criteria are clinical ones. At the same time, they're used as a certain scale. So it helps document, it helps assign points to come up with scores and come up with a prognosis. Whether a patient will get benefits from an ICD or the effect from that will be minimal with respect to post-implantation SCD prevention. Once again, cardiac MRI, let me revisit that. There is a very, very interesting meta-analysis recently published last year. It was LV mid-wall fibrosis as a predictor of sudden cardiac death in non-ischemic dilated cardiomyopathy, the non-ischemic DCMP. It was shown that the use of this method and the detection or identification of the mid-wall fibrosis was negative predictive value. If there is no such finding, then the prognosis in these patients is quite favorable. And negative prognostic factor, if it's there, if the mid-wall fibrosis is there, we should implant the ICD. NNT could be, well, in this case, the intervention is 2 times more efficient. So the authors of this trial suggest using the fibrosis of the mid-wall as a prognostic factor, the LV mid-wall fibrosis as a prognostic factor, and use it as one of the criteria to recommend ICD implantation in patients with non-ischemic cardiomyopathy of the left ventricle, regardless of the LVEF. So we see a second category of patients with a higher than currently used by us, higher ejection fraction than the 35% that we were bound by. All-cause mortality is reducing, cardiovascular mortality is particularly reduced using that approach. Another meta-analysis that was done to look at the sustainable ventricular tachycardia or persistent tachycardia. Genetic workup can be beneficial. The MRI findings, ECG, electrophysiological studies can be useful. These combined can help run more diagnostics more successfully. Multi-factor model using this to predict, using this as predictors looks promising. Patients with IHD, with a history of MI, there was a preserved EF RCT done for them. Combined approach in risk stratification for arrhythmias, a multi-center prospective observational cohort trial was done for patients with LVEF over 40%. At least one factor was supposed to be assessed. So the patients had to have at least one non-invasive EKG risk factor, PVC, SVT, RV, elongation of QTC, increased T-wave alternation, decreased HRV, abnormal TRS. They were referred for IEPS. The primary endpoints on follow-up included the development of sustained ventricular tachycardia, VF, motivated by the activation of CVD or SCD. As a result, the two-stage algorithm helps identify the population of patients with a history of MI with ejection fraction under 40%. What's more important is that the algorithm had 100% sensitivity and 94% specificity. Positive prognostic value was 22% and negative prognostic value was 100. So not a single patient without the risk factors or with risk factors but without the induction of ventricular tachycardia, they did not have any criteria to reach the primary endpoint. So we see two different algorithms, at least from the two trials that I've shown. In one case, it's patients with ischemic cardiomyopathy with preserved ejection fraction who do not have indications for implantation of an ICD. And the second case was non-ischemic, second trial for non-ischemic cardiomyopathy patients with this. In this case, this trial is particularly beneficial. Preserved EF data, again, it shows us statistically significant results when using this algorithm. When we see clear separation into clusters. Differentiation of patients is facilitated by clustering them. Some patients have no indications and we do not subject them to risk because we don't subject them to risk of leaving them medical aid free. Prevention of SCD is unthinkable without comprehensive lifestyle modification, risk factors modification if there are risk factors. Of course, the therapy must be looking at the original condition, the underlying condition, but given the heterogeneity, there are various approaches to treating the underlying condition. The bulk of the patients are those with IHD, ischemic heart disease. In this case, we should be looking at revascularization, myocardium revascularization indicators, and various methods related to device implantation can also be indicated. ICD or CRT. In most cases, the RFA is used. Medical therapy is often well developed. New classes of pharmaceuticals have come out. we are not separating patients. So most of them are taking ASA, beta adrenal blockers, ACE inhibitors, ARBs, the new class of pharmaceuticals, sacubitril, valsartan, statins, for example, are important in cardiomyopathy. We have to use statins. Antiarrhythmics, patients with heart failure, it's mostly amiodarone. There's not too many choices there. Pharmacotherapy for ventricular arrhythmias, we cannot use 1C class. Beta adrenal blockers are often the first line, and they're used even in the toughest cases in combination with amiodarone. Chronic heart failure recommendations, they're listed here. The list of pharmaceuticals includes 1A class. A few words about valsartan, sacubitril, if I may. Paradigm EHF was looking at biomarkers for extracellular matrix. There was a positive impact of sacubitril valsartan. SST2 and TIMP1 went down on sacubitril valsartan. Also, there was a statistically significant MMP9 reduction, metalloproteinase 9 went down. And also, most importantly, sub-analysis showed that unlike previous use of ACE inhibitors, or for example, these kind of the replacement of these pharmaceuticals for sacubitril valsartan, it gives us very good results for reducing the number of episodes of unstable VT, the number of triggers of the device. Bottom line, we had a very good result in terms of clinical status assessment for these patients. Patients with acute decompensation of heart failure deserve a separate attention, specific attention, because these are the patients prone to ventricular arrhythmias. Ventricular storm might develop. Patients with acute coronary syndrome are these. Patients with electrolytic disturbances, other associated issues can be the cause. So this category of patients, of electric storm patients, they require specific monitoring, stringent follow-up. Oftentimes, it is these patients with QT interval elongation. In many cases, it's because of the associated COVID infection. Summarizing my presentation, these are the conclusions, these are the diagnostic methods. Mostly it's standard EKG methods, there are many of them. However, at the same time, there are imaging methods such as EKG, MRI. They also deserve, they also have a rightful spot there. These methods are not new, we have known and studied them for a long while. However, now the time is approaching when we've had certain selective groups of patients, that we need to follow up according to specific algorithms so that the most meaningful results are studied, analyzed properly so that we can extrapolate this data to a different subpopulation, patients with ischemic or non-ischemic cardiomyopathy. Depending on the selection of the methodologies, we can consider other approaches. Basically, it's ventricular rhythm disturbances, SCD potential, or patients with rapid progression of heart failure, severe decompensation outcomes. Comprehensive approach is very important here. The use of OMT based on the evidence-based medicine, and the use of all the methods that are available, have been developed to date, that can be used. Today we have seen several wonderful talks by our colleagues that were looking at CRT involving the new methodology for the heart conduction system, and so on and so forth. So I believe it will take some time, some short time frame, for the experts, for the global experts in arrhythmology, in cardiology, to come up with a different set of guidelines for these conditions. Thank you very much for your attention. Any questions? Victor, thank you very much for the talk. It's a powerful presentation. I even made several snapshots without your permission, but with your permission, I would like to use them later on. Most recent findings, most recent results. Oftentimes, cardiologists ask us, they love amiodarone, cardiodarone, and they always ask, does amiodarone or cardiodarone work to prevent SCD, especially if we're looking at secondary or primary prevention? Your opinion, to go for it or not? The trials are not showing that it's too helpful in preventing SCD. What about your opinion? Yuri, there are various trials, there are meta-analyses. Some of them have said that it does not affect mortality. However, well, I have failed to cite that meta-analysis in my presentation, but I have it right here that yes, there is evidence of arrhythmic-induced mortality. Most likely it depends on the cohort of the patients. For example, if it's patients with ischemic cardiomyopathy, then most likely we will get a longer benefit. However, I will warn against the long-term amiodarone prescription, because what we want is to prevent mortality in 1, 3, or 5 year time frame. Amiodarone is not prescribed often, I mean for a long time, at least in high doses. If the situation requires in patients with ICD and with frequent triggering of the device, yeah, in that case, we're supposed to prescribe it for a long time. However, if the patients are free of ICD, there's no implanted device, the risk might be quite low. Even if the ejection fraction is more than 40%, a patient with cardiomyopathy, with chronic heart failure, well, we're not using amiodarone for a long time because we don't want toxicity to kick in. We don't want those adverse events. Unfortunately, we don't have anything aside from amiodarone to try to combat the extrasystole, the unstable VT. Sotalol is much worse in this respect, especially for the QT interval, its length. Sotalol has 10 times higher frequency of development of these adverse things. If it's hypokalemia or creatinine level elevated, sotalol brings higher complications. We're not reducing risk, we're increasing risk because of that. Other groups are not desired for the patient, other groups of drugs. Okay, great. Thank you for the wonderful talk. Let's get a flashback of the 8th webinar. Thank you. And then we will announce the 8th talk of the day. Syncope. So, moving on according to the agenda, the 8th talk is the use of neurostimulation methods in treatment of patients with cardiovascular diseases and atrial fibrillation. Professor Yakovlev, Moscow, Russia, Medelec Clinic head, please share your knowledge with us. Yes, indeed, dear colleagues, good afternoon. Thank you for the opportunity to talk before this wonderful audience. I'm a neurosurgeon by background. Functional neurosurgery is my field. So when I started delivering talks at cardiological congresses, say 5 years ago or so, my topic was quite limited. I mean, quite limited interest. Arrhythmologists, cardiologists. I remember the first lecture was attended by 2 or 3 people. Now, in St. Petersburg conference, just 5 years later, there were 2 separate sessions dedicated to functional neurosurgery, which is to suggest that there is a higher interest from clinicians. The manufacturing companies have come up with new technologies that I will get to mention in my talk. Well, first of all, what is functional neurosurgery? Well, this area is using minimally invasive methodologies, particularly neuromodulation, the traditional resection destructive therapy, surgical destruction. All major surgeries come with certain downsides. There are several issues that I've put on this slide. It's not just for neurosurgery, it's for general surgery, any surgical field out there. So resection and destruction, it's long duration, traumatism, high level of trauma, high risk of complications. The efficacy is limited by 50–70%. Contraindications are sometimes there, and it's irreversibility. What you've cut off, it's very impossible to bring back to life, to suture back on. So if you're talking about urgent surgeries on spinal cord, it's quite low efficient. The efficiency is quite low. So the issue, the complications are 30–40% and higher. The overall surgical complications for spinal cord, even for the spine, I mean, death 0.2%, 1.5% infection, even higher. Deep vein thrombosis, DVT 3–7%. PE, pulmonary embolism 2.2%. When patients end up in ICU with a serious 50% plus nerve damage, there is also rejection of grafts. LACE methodology came up. This is a very interesting mild procedure for patients with mild stenosis that helps save patients' lives and extend their lives. What is neuromodulation? This is the main direction, which is now developing functionally. Functional neurosurgery, functional neuromodulation. Cardiology and arrhythmology, there are novel developments there. We used to know about electrical stimulation, but I will talk about targeted drug delivery. The companies, the manufacturing companies are well known. Our technology is similar to Medtronic pacemaker defibrillator technology. The company was founded in 1949 in Minneapolis suburb. Medtronic has grown to become a huge international giant. Spinal stimulation is most frequently used in functional surgery. It is the easiest one. No anesthesia, minimal mortality. The electrodes that are implanted on the CR Normally, we implant 2 electrodes to get the best effect and then reprogram the signal. If there are any mechanical problems, spinal delivery of drugs, this is the technology that helps reduce the dose of the drug from 100 to 300. I mean, the drug is delivered exactly to the target receptors, much higher bioavailability. So the drug is getting through the blood-brain barrier. You don't have to take, or people don't have to take pills with too much stuff and side effects when there are liver transformation of the drugs. You see the converted doses. Oral morphine, 300 milligrams per day. Intrathecal morphine, 1 milligram per day. So for baclofen, it's 100% reduction. The founding fathers of this therapy were American surgeons, James Corning and Rudolf Matus, late 19th century, New Orleans. Then the technology was developed by August Beer, a well-known surgeon and anesthesiologist back in late 19th century. In 1980s or in late 1970s, the first devices came up that helped treat oncological pains by intrathecal morphine injections. Medtronic technology emerged in 1991. It helped the first programmable pump called Synchromed. It gave the opportunity for non-invasive correction of pharmaceutical doses using the external programmator. The technology kept evolving ever since. It has become a reliable and convenient way. However, there are more and more patients with arrhythmias, with heart conditions, other heart conditions, regardless of the numbers of medications that are available for use. Statins, various effects from these pharmaceuticals are also, patients taking these pharmaceuticals end up in neurological clinics, in particular with various forms of neuropathies. Also, these patients, many of these patients, are coming from the fast food industry, or so-called victims of the fast food industry. And basically, some of the pharmaceuticals simply give no help, or are no help for them. Revascularization, PCI or CABG, it's mostly catheter, percutaneous intervention, or the use of CABG, coronary artery bypass graft. Basically, these have been optimized using drug-eluting stents. You can use the off-pump technique, but these technologies have evolved to the pinnacle. They have reached the top, as you can see in this slide. There's been an active search for the past 30 years what can be done and what can be offered to patients with ischemic heart disease. All of us know that even angioplasty, even catheter technology, 1 to 2% mortality. This is a routine figure, or that's a routine use figure. The death, depending on the situation, might reach as high as 6%. I just know the Russian statistics on that. The cath lab complications are listed in this slide. Well, most of all, it's dysrhythmia, it's ischemic complications, renal dysfunction and renal failure, and so on. Contrast-induced trauma. For CABG, it's death, which is quite high, around 3%. Arrhythmias up to 60%, renal insufficiency, and the number of neurological complications. In 1998, there was an article published in Circulation, the American journal. Two groups of patients were compared, CABG and spinal cord stimulation, SCS. The clinical results were quite close, but the SCS group presented much lower mortality and non-fatal morbidity and total morbidity. We are using SCS more and more over the past 2 decades. So what are the SCS effects in myocardial ischemia? Well, they're quite well studied. However, more and more articles are coming out showing various new findings. Well, first of all, the decreased myocardial oxygen demand, there's improved myocardial perfusion. Cardioprotective action of calcitonin gene-related peptide, ADM, nitrous oxide, and beta endorphin. I would like to highlight not just the neurostimulation, but also the use of epidural analgesia anesthesia on refractory angina pectoris patients with IHD. This methodology can be used in patients who are candidates for revascularization in the future. We know that up to 30% of patients with a history of CABG, 1 year on, 1 year post-op, they start experiencing angina pectoris symptoms again. The angina comes back. For which reason? There's another technology that has come up. This is a Swedish article. The use of dosed local anesthetic delivery. Subcutaneously tunneled epidural catheter. The patients can use the drugs themselves, which helps improve their functional activity, which helps boost their life quality after all. Ventricular arrhythmias treatments. That area has an extensive experience of using surgical methodologies. There are minimally invasive methodologies that have come out, such as stellate ganglion block, cervical vagal stimulation. More and more methodology is coming up. Has been coming up ever since. So this is the stellate ganglion block, which helps patients with ventricular tachycardia they can live through the acute period. They can be transferred to the cardiac centers. There's a lot of information in the literature suggesting that these patients can live for quite a long time without any cardiosurgical methodologies on the just on this therapy alone. The literature involves quite a lot of information about the use of electric storm technology. This is what the thoracoscopic sympathectomy looks like. Until these days, RFA of the pulmonary veins, pulmonary vein isolation was used. Unfortunately, this methodology causes a lot of issues, causes a lot of questions. After the publication of the article, a multi-center Cabanas trial, it showed that in some category of patients, this approach, well, basically the statistics is similar to those patients who still continue optimal medical therapy, optimal drug therapy. Unfortunately, all catheter technologies, including ablations, are not complication-free, and they can also become lethal. I mean, mortality is not zero, clearly not zero. So, enhanced stimulation using special systems, implanted devices like this slide shows have come out. Now there are new manipulations that have been developed, endovascular ablation of the right greater splanchnic nerve, which is reducing the efficiency, the activity of the sympathetic nervous system. You can hear me, right? Yeah, yes, we can, but the sound is really, really poor. Okay, so what we see there is the reduced activity of the sympathetic nervous system. There is a restoration of the volume of the vessels of the abdominal organs and decreased preload and improved left ventricular function. Endovascular baroreflex amplification, baroreflex amplification, and carotid body modulation. Stenting technology with elongation of the vascular wall, dilating the vascular wall, which reduces the sympathetic nervous system activity. This is the new method, the new methodology, fairly promising one, fairly promising tech, using the transvenous stimulation of diaphragmal nerve. Patients can be treated by cardiologists, arrhythmologists. 77% of patients with sleep apnea, with OSAS particularly, with CSF, they have heart failure and reduced ejection fraction. Essentially, this technology involves implanting electrodes. One is sensing, one is stimulating. So sensing lead and stimulation lead. The function is reducing arrhythmia and expanding lifespan, or improving lifespan, prolonging life. Acceleration of blood is reduced, CO2 reduction, CO2 filtration reduced, respiratory function is improved because of that system. In the recent couple of years, there have been publications, particularly in the Russian literature. There was the first domestic experience of treating the patients with atrial fibrillation. So the doctors actually use continuous spinal cord stimulation. That patient with a number of cardiological centers, medical therapy, radiofrequency methods we use cardioversion. Unfortunately, she was unable to come back to steady sinus rhythm. It was a chronic AF. At the time of admission from a neurosurgeon center to our clinic, we still not accepting symptoms. After tests, we implanted leads, upper, lower spinal cord sections, cervical, thoracic sections of the spine. We were able to remove spinal stenosis symptoms, and we also got back to sinus rhythm. For the past 5 years, the patient has been doing well. She's able to engage in professional activity. She has been on sinus rhythm. At the time of admission, she was actually using a wheelchair. Lower limb edema because of apnea was quite a bunch of very nasty symptoms. We've been able to treat just by this. There are also broader experiences. Unfortunately, this is a retrospective article. Treating patients with concomitant cardiological, neurological pathology. All patients, very poor condition initially, sinus rhythm as an outcome. This is another work, Alexander Romanov. It's basically a prospective trial, looked at the group, 26 patients in the control group and 26 patients in the SCS group. So half the patients received heart surgery, CABG. The stimulation was 3 days before and after the CABG using the lead groups. The group with electric stimulation had very good results. Only one patient experienced a recurrence of AF, but it was well controlled. It's in line with the so unfortunately the sound is really poor, so I'm just getting isolated words there. So it's a life-saving method. The implantation of the lead is done for the cervical the lower cervical part, C7, the thoracic 4. There are no complications related to surgical part in SCS patients. The stats were completely amazing. I believe this trial has precipitated further works. It has paved the work for further research, for further trials that will improve the outcome for these patients with coronary arteriosclerosis, particularly patients who are eligible for CABG. Because right now the morbidity and the lethality post CABG, well, it's quite a bit of a burden for both cardiologists and cardiac surgeons. If that statistics is improved, well, it's really going to revolutionize cardiosurgery. So what are the prospective indicators for spinal stimulation? X syndrome with peripheric atherosclerosis of heart vessels. Professor Romanov, whom I cited, have used that in his work. So basically, combined use with CABG surgery in patients with high surgical risk is a good use for this technology, and peri-op use in heart and lung transplant surgeries. Something about genetic conditions, electric pathologies, and electrophysiological pathologies. Spinal stimulation can also be used as an addition to GP or RFA in atrial fibrillation, and vagus form, idiopathic AF, neuromodulation of the conductivity speed in the AV node in case of tachyform atrial fibrillation. So the future is clearly bright for this technology. Those experts who have mastered this technology, so have gotten the right skills, they will be able to use them successfully and develop the technology. Unfortunately, the sound has gone completely poor. I believe that in a couple of years down the line, we will learn a lot of new things. We have a lot of plans ourselves in terms of development of our toolkit. So should you have any questions, I will be pleased to take them now. Thank you. Thank you, Alexander. Impressive talk, indeed. So I'm amazed, positively amazed by it. Some things I do myself, like, for example, a lot of CSF has been done. Bless the vagus plexi, nervous splanchnic would do it, splanchnic nerve, patients with heart failure. We do this a lot ourselves, but I believe, yes, there is a whole number of technologies about to emerge, and we are peaking at our opportunities. We don't have to damage, we need to modulate, we don't have to cut. So any questions to our esteemed speaker? Dear audience? Okay, there seem to be no questions. Thank you very much, Alexander. Looking forward to your scientific publications and looking forward to seeing you at our webinars. As far as I'm aware, there are no further flashbacks, right? That's right, yes. The final, the ninth one, has been already shown. The next presentation is up. Basically, it will be presented by a PhD in medicine, Vladimir Syrovnev. He'll be talking about the modern technologies for mapping atypical variants of atrial flutter in clinical practice. Yes, can you hear me, see me well? Yes, we can. My name is Vladimir Syrovnev. I'm the surgeon arrhythmologist at the Burdenko Hospital, the military hospital. This is my disclosure. My presentation will be dealing with two issues: arrhythmias with COVID-19 and high-density mapping in treating severe rhythm disturbances. The viruses have been pestering people for a long time. In different periods, we register higher or lower incidence of pathogens that can cause myocarditis. It's various kinds of viruses: adenovirus, parvovirus, B19. In the past year and a half, there's been a serious spike of the new coronaviral infection, which is tropic to angiotensin converting enzyme, ACE2. And it can trigger myocardial damage as well. The pathogenesis in COVID-19, same mechanisms work and is in other ones: cytokine storm, direct balance disturbances, respiratory insufficiency, acute cardiac insufficiency, and microvascular dysfunction. Thromboembolic plaque can get ruptured with further scarring. This triggers all the consequences I've listed in the slide, as well as the arrhythmias that we'll get to talk about in more detail today. September last year, there was an article published looking at cardiac arrhythmias and COVID-19 in patients with a severe course of the disease. They have higher incidence of cardiac arrhythmias, 7.6% in total. However, comparing COVID and influenza, A and B influenza, there was no difference in atrial arrhythmias, atrial fibrillation. 4, 6, and 4 de novo cases of AF, which basically says that it doesn't matter which virus it is. In this trial, the risk of arrhythmias was explained by the existing comorbidity, marked inflammatory response, and myocardial injury. So myocarditis that is developing at the backdrop of new coronaviral infection, COVID-19, is provoking arrhythmias or causes the de novo arrhythmias in patients. The severity of arrhythmias depends on the severity of the course of the disease, concomitant pathologies, and the immune response. 3D nerve systems can help treat such patients. We can boost the efficiency of myocardial biopsy and make it more targeted, as this example shows. Using the navigation system, the nav system, the electroanatomical voltage mapping has been done. This map was compiled. And then, from the area with the transitional myocardium and the normal voltage, the biopsy was done. So in one case, this transitory myocardium, we saw a granulomatous damage. In the site with intact voltage, we got normal findings. The histology came up normal. The image on the right shows the methodology for this biopsy. You see the focus here with electroanatomical map was used, and the biocurrent is supplied there. This kind of mapping does not only help diagnose, but it can also detect the activity of inflammatory response. In active phase, the mapping will be problematic because of multiple foci, as this slide here shows. And the efficiency of ablation will be lower than compared to the borderline myocarditis. This is our trial of 2017 in Almazov Center. It shows that the borderline case, if the myocarditis is borderline, the RFA is much higher. RFA efficiency is much higher. Recurrence of arrhythmias can be diffuse. It requires high density mapping. We need to look at the substrate of arrhythmia to predict its recurrence. This special catheter, mapping catheter, is used. It's called Intelemap Orion. You have 8 arches of 0.4 millimeter square leads. There's quite a lot of them. By reducing the size of the leads and the spacing between the leads, its resolution capacity is increased. So this is the typical atrial flutter. When using the conventional thresholds of the noise, the mitral isthmus, there is only a scar, and the activation is not displayed. Basically, we can miss this section. However, if we reduce the amplitude threshold to 0.01 millivolts, 100 millivolts, 10 microvolts, we basically find this critical isthmus for the arrhythmia. The mapping results determine the efficiency or the efficacy of the surgery. It was done comparing head-to-head various navigation systems and treating atrial fibrillations. High-density 3D electroanatomical mapping can reduce the long-term recurrence of AF by 13%. High-density mapping helps visualize localized re-entry tachycardia that might happen in cardiosclerosis. This is the cycle around a small scar, eccentric spread of activation of the signal from it. Now, micro re-entry opportunities have been used by Lenso study group looking at driver activity LATSU. They were able to reduce atrial fibrillation down to 18%, 1-year recurrence, AF recurrence. High-density mapping can also be used to locate occult, silent manifestations of AF. The RFA will only benefit from that. Kaplan-Meier curves go to suggest that. Low amplitude signals detection with high mapping technology is helpful. Is helping treating epicardial ventricular tachycardia. This could have been construed as a dense scar if we were using 500 microvolts as a threshold. if we increase the threshold, if we increase the resolution, I mean, the dense scar under 100 microvolts, this is where we saw the late potentials. This scars modification, removing all the late potentials, is reducing ventricular rhythmic storms. The number of ICD triggering is reducing because of that. This particular example showcases a patient who we did a surgery on several months back, 2 months back in Chelyabinsk. Acute myocarditis with heart failure developed in this patient since 2014. There were issues with supraventricular and subventricular pains, tachycardia. There was an attempt of RFA in 2019, attempted RFA. It got no effect, brought no effect. And finally, the patient had an ICD implanted. However, there was thyroid toxicosis, stereotoxicosis. Cordaron was cancelled 1 year after it was prescribed, and the patients started experiencing VTs and ventricular flutter, ICD trigger. We hospitalized him for that reason. In this case, you can see that, and this is the epicardial map. You see a huge scar along the anterior and lateral and the posterior wall that is not obviously not shown here. The scar was huge, transmural. I've also displayed late potentials. There were quite a lot of them along the entire cardiac chamber. We had to invest a lot of time using a special catheter even to map these potentials and to remove them. However, our effort was fruitful. There was no AF recurrences, and there were no triggers of ICD. It was quite tolerant clinical picture of ventricular tachycardia that the patient could live with. So, summarizing my presentation, I would like to say that high-density mapping, it boosts long-term, short-term efficiency in treating atrial and ventricular arrhythmias, and it may be the method of choice in treating complex cardiac arrhythmias. Thank you very much for your attention. Dear colleagues, please feel free to join. Please feel free to ask your questions. Vladimir, thank you so much for the talk. I would like to specify the epicardial mapping electrode. What does it look like? The same as for endocardial? Yeah, roughly the same. Basically, it is the same. It's a Ryan catheter. It's kind of a basket with 8 arches, 8 lead arches. It's just we don't open it in epicardium. It's closed when we're working in the epicardium. But yeah, you can basically use it. You can use the MiFi. Also quite small leads that help map many points quite quickly. Also quite convenient. I have a question to you, Vladimir. For the first part of your presentation, for that biopsy that you've made, how do you recommend using this with other systems, other nerve systems? Does it make sense? Because we are guided less and less by biopsy as a way to diagnose this myocarditis, because they're mostly spotty, and you're trying to detect that area where the biopsy is supposed, well, the needle or the catheter. That's right. Yes, the mapping is serving exactly to that, to specify the site for biopsy. It's a very good question, by the way, because oftentimes there can be diffuse changes in the myocardium which are very tough to detect. Nobody is going to pick that up. Ventricular sections are all, ventricular portions are also not exactly safe because the sites with the lesions, they're thinner. They're easier to nick. They're easier to perforate in this respect. So the first line of diagnostics, it could be MRI. In the 2018 consensus, they also suggested the MRI to be line 1 or the first line of diagnosis. Endomyocardial biopsy is remaining the golden standard. However, the MRI is so advanced now that we can determine the activity of myocarditis, endomyocarditis. And it is safer. MRI is safer at any stage of the disease. So yes, the biopsy is still the gold standard, endomyocardial biopsy. However, unless you map, you can select several samples from multiple sites, and oftentimes we will get nothing, although we will know it's there. So these sections that we use for biopsy without mapping give us zero diagnostic sensitivity. Mapping helps us guide the biopsy. The case that I've shown was sarcoidosis. In sarcoidosis, the lesions might not be diffuse, they might be just focal. So in this case, yeah, the mapping was the way to go. It made sense to do the mapping. But yes, the question is quite ambiguous. Yes, thank you very much for the great talk. We wish you success in your scientific endeavors. I believe that the scientific agenda has been exhausted. The webinar number 10 of the Eurasian Arrhythmology Association is almost complete. If there are anyone from the lecturers, from the speakers, let us look at each other one last time today. Otherwise, well, we've done a lot of work. The Eurasian Association has done a lot of work, put in a lot of effort. In mid-September in Minsk, we plan to hold our second session. A scientific program is already there. I believe it is quite serious, quite decent. It will be within the framework of the Belarusian Cardiology Congress. There will be a number of EVRA talks there. I wish to thank the reporters from the bottom of my heart. So like every single speaker was the best. It's impossible to select the most advanced one. I wish to thank our IT support group, which has been quite steady, 5 hours with us. Everything has been successful. We're going to spend the weekend with our families. Hopefully the weather is going to be quite good in the Eurasian space. Wishing success to everyone until we see each other again at our conferences and webinars. Thank you very much for your attention. Thank you. See you.